This conference will now be recorded.
Okay, thank you. So, labor management we're going to do today. So let's start. Who is the first one to start?
Sadia.
Hello, Satya.
Hello, good morning.
Good morning, Satya. We have been hearing from you after a long time, so
Yes,
I
Dr.
think you have
Julia,
been really
apologies
keeping
for that.
busy.
Yeah, because
Yeah.
it was August and layover time. So there were so
All
many
right. Oh, yeah.
schedules that I was asked to
That's right.
cover.
Yeah. Yeah. August is always a bit tricky one.
Yeah.
Right. So this is for you then.
Okay.
Hello. Hello.
Hello.
Yeah, Assalamu alaikum, Dr. Satya. There is
Yes,
too
Ajina.
much noise. Too much noise. Two girls, they have open mics, so probably it's because of that. But it's very noisy.
All right. Okay.
Yeah, now it's
Everybody
okay.
else, put your mics off. Thank you.
Thank you.
That's great. Yep. Okay. Satya, you can start. Your 2 minutes are over.
Okay, thank you. So I'll approach this patient. I have been given the information about Sarah Jones, who is 36 weeks into her pregnancy, into her first pregnancy, and she was admitted with history of tightenings. And when I entered the room, Sarah is found to be unconscious. So I will quickly approach Sarah in a safest manner, and I will pull the emergency buzzer to call for more help. It would include midwives, my senior consultant, anesthetic team, and also the other senior coordinator midwife, also someone to scribe. So I will pull the emergency buzzer calling for help, and then I will approach Sarah. I will see, I will listen and feel. I will check whether she is breathing, whether she responds to my voice, verbal command, or whether she opens her eyes or not. Do I have any further information?
No, that's all. So you found her unconscious. How you proceed?
Okay, so I will see that she is not responding to when I ask her to open her eyes, and if I feel so supposedly if she is unconscious, I would assume that she is breathing, but she is mm, just not communicating with me. So I will, with the help of my team, which arrives, I will transfer Sarah to a position which is the recovery position. Either I would transfer to a bed. If she's on the bed, then I would make the bed flatter with left lateral tilt, or I will ask someone to hold her gravid uterus to left side so that to relieve the pressure onto the big vessels, aorta and vena cava. Um, and then I would start with ABC. So airway, I will check her airway. I will check her breathing, if she's breathing, and I will check her circulation by giving her two large bore IV lines. I'm assuming that my team would arrive at this time. So I would pass an airway if there is any obstruction, and I will give her oxygen by face mask, 15 liter per minute of oxygen. And I would immediately ask my anesthetic colleague to pass two white bore IV lines and give some fluids. In the meantime, I will start assessment of what may be the cause of any um, of her symptoms. So my treatment, management, and to find out the cause will go side by side in such scenario. I would quickly have a head to toe view of whether she has any trauma, whether she is bleeding, um, what is the cause of her being unconscious, because if she was a preterm, came with history of tightenings, she might as well have some vaginal bleeding and abruption. So I would look for that, and I would ask someone to contact the hematology team as well, and to put out the resus call, so the proper resus team can arrive me in the meantime. Um, in order to continue this station further, do I have any further information regarding?
No,
Um,
no, there isn't any. She's unconscious. She's still unconscious.
okay. Then I will check her cardiac rhythm, whether she has the heartbeat or she is in cardiac arrest. So that is also one thing. If there is no heartbeat, or if she is in cardiac arrest, then I would check whether it is a shockable or an unshockable rhythm. Um, I would attach the defib monitor, and usually the monitors that we have, um, they are automatic, and they tell us whether this is a shockable rhythm or not. If it is shockable rhythm, I would give shock, deliver shock. In the meantime, keeping everyone safe and to stay away from the patient while the shock is delivered. And then we will again start the resus straight away after that. Every 2 minutes we'll see. However, if it's not a shockable rhythm, that I will continue with my CPR, and I will keep assessing every 2 minutes whether she has any cardiac output which has returned back. So even after 4 minutes of CPR, if we do not have her cardiac output, then I would make this decision in liaison with my consultant to have the perimortem cesarean section, and that is for the improvement of the cardiac function of the mother, rather in mother's interest rather than the baby's interest. So I would do it in the room. Deliver the baby. Aim is to deliver the baby within 5 minutes of the cardiac arrest. And if and after that we don't close, we simply pack it with a pack, and we continue the resuscitation. If the cardiac output comes back at any point, then we will transfer her to theater and close her there. However, if it doesn't come, then we will continue the CPR within the room. Is there anything else?
No, that's okay. So you can conclude here what you need to do after resuscitation.
So I can, yeah. So in conclusion, when I see an unconscious patient, I would first resuscitate her. I would call for help. I will check what sort of resuscitation she needs by seeing, by feeling, and by listening. Then I will start with ABC, airway, breathing, circulation, and if there is no cardiac output, if she's in cardiac arrest, I will start CPR. I would have my senior obstetrician, the consultant, the senior anesthetic, the resus team, a senior midwife, and also the scribe, as well as the hematology team to be informed as well if there is a need for blood or blood products. So I will have all of this team and we will do it together.
Yeah, okay. So can you tell me the most common causes of cardiac collapse or the collapse in a pregnant woman?
So few of the most common causes are the cardiac conditions, venous thromboembolism, bleeding, which can be APH, PPH. There can be eclampsia, preeclampsia. There can be epileptic fits, and there can be CVA, cardiovascular accidents, or stroke, and pneumothorax. And uterine rupture. So these are the few causes.
Okay.
And
Yeah,
any
that's fine.
infection, yeah, any infection as well, like meningitis or any other sepsis. So that can also be the cause.
All right, okay. Right then. So yeah, that's fine. Thank you. So this is a very fixed algorithm we need to follow. It's just the CPR and the your basic life support you do every year. So you literally need to just kind of regurgitate that rehearsal which we do. So yeah, so when you see an unconscious woman in the room, because she is in the room already, so yes, the first thing you will do, you will pull the buzzer, emergency buzzer, so you can help because it's a pregnant woman on the floor. And then you just need to, keep saying things which we do and we rehearse in every year in our training. So all you need to do is you will say, so I will approach the patient. I will make sure it's safe for me to approach the patient. Then I will go close to, I will call her by her name, Sarah. Sarah, are you okay? Then I will gently shake her shoulder to check the response. Sarah, are you okay? And if she's not responding, then I will, listen, look, and feel. So I'm going to just do the head tilt and chin lift to clear the airway, and then I will try to listen and feel for the breathing, and at the same time I will check her carotid pulse. So if there is no, breathing, then you quickly going to check the airway. So I will open the mouth to check if there is any obstruction. And then, if there is no pulse as well, then I'm going to call for help. No, this is the second call for help for the resuscitation team. So I'm going to ask my colleague to call the cardiac resuscitation team, obstetric resuscitation team, and tell them a pregnant woman is unconscious on the delivery suite in room 4. And they will open the doors of the delivery suite as well, so the team can approach quickly. Then I will immediately start the chest compressions, which will be at the speed of 100 per minute. I will make sure that the depth of the compression is to ensure 1/3 recoil of the chest wall. And then I will ask the midwives to start giving her oxygen through the oxygen mask. Yeah, so because we are in the room, we don't need to go for 2 breath and 30 compressions. So we can just simply go for the mask there. So the chest compression will continue. You will ask somebody to bring the defibrillator from the, delivery suite. We have automated defibrillators present over there. So as soon as the defibrillator arrives, you will hand over the chest compressions to one of your colleagues, and then you will attach the defibrillator pads after making the exposure of the chest. So one pad, you can say the defibrillator comes with the instructions of the pad application and everything. So one pad will be applied on the right side, just below the second intercostal, just on the second intercostal space vertically, and the other one will go on the left side, just below the nipples, towards the mid-axillary line. And then you will switch the defibrillator on, and it will start analyzing the rhythm. And the chest compressions will continue during that time, and as soon as the defibrillator has analyzed the rhythm, if it's shockable rhythm, which is ventricular tachycardia and ventricular fibrillation, then I will prepare to deliver the shock, and I will make sure that everybody's away from the patient. I will tell I'm ready to give the shock, everybody away, oxygen away, and then I will deliver the shock. Immediately after that, the chest compressions will continue, they start again. When the resuscitation arrives, then yes, you will hand over the the resuscitation and chest compressions to the resuscitation team. Meanwhile, you will ask one of your colleagues to pass to white bar cannulas and take the bloods for full branchial UNEs, toxins, and the coagulation profile. And then you will be thinking about the reversible causes of the cardiac collapse, which are 4H and 4Ts. And obviously we need to have we need to remember those. Yeah, so the H's are hypoxia, hypokalemia or hyperkalemia, and then hypothermia, hypovolemia. These are 4 H's, and then your 4 T's are tension, pneumothorax, tamponade, thrombosis, and toxins. And yeah, you can say in the pregnant woman we can consider the eclamptic fit as well, but the eclamptic fit is different. The woman doesn't go complete unconscious in there and that way. But anyway, that can be when we say VD. These can be, the 4 possible causes. So you will, meanwhile also ask the midwife to give you the, if there is an attendant as well in the room, then you will encourage the attendant to give the information, what exactly happened just before she collapsed. Did she complain of any chest pain? What she complained? And then you will ask the midwife or some other colleague to read the notes and give you that information as well, so that you can start reversing the reversible cause. If the CPR is not successful within 4 minutes, then we will proceed to perimortem cesarean section. And then yes, it's important to say that it is absolutely just for the sake of the mother, to improve the circulation by relieving the pressure of the gravid uterus. And it will be done, just with the scalpel and deliver the baby quickly. Apply the clamps, unpack and leave it there, and continue with the CPR. So when we say the obstetric, I'm just going to have a little gap at this. When we say the obstetric resuscitation team, just for the knowledge, I mean, whether you say or not, as long as you say obstetric resuscitation team, that will include everybody. But if you want to say, that will involve, we know the bleep goes to anesthetist, obstetric anesthetist, that goes to the resuscitation team, that goes to your consultant, that goes to coordinator midwife, all the midwives and everybody, so they all can attend, who is free to do so. And then, yes, sorry. So in the beginning, yes, the first thing you're going to do is to tilt her slightly towards the left side by using either the pillows or ask the midwife to slightly tilt till you guys have the spinal wedge available to keep in that position, right? So coming back to the perimortem stage. So then after that, obviously there can be two possible options, possibilities. Now, if the patient revives, then the patient will be transferred to the theater, where obviously the suturing of the uterus, and you will close, and then the woman will be transferred to intensive care unit. And then by that time, if there have been any cause being identified, then obviously there will be aftercare will start and continue according to the cause. And once the patient is awake, you will make sure that you will go and the consultant will go as well, speak to the patient, explain her the events, explain about the interventions which took place. And it can be a bit, terrified experience for the women. So you will make sure that if she has any questions, they are being answered, and if she requires any counseling and support, that is being offered to her as well. And before, you will then complete the risk assessment form as well to report as an incident for the analysis. And then you will also make sure before the woman is discharged, you see the woman again if she has any further questions to ask her, and then arrange her appropriate follow-up in the obviously postnatal clinic, as well as in this specialty according to what the cause is identified. So that's if the patient survive and revive. And obviously you will, immediately after in the theater, you can imagine now you will be doing team briefing to see what went well and what could have been done better. And, that's all, happy ending. If the patient doesn't revive, then after obviously some time of continuous CPR, the team lead will decide to declare the patient dead, and that will be done obviously by the consultation, by the combined decision of the resuscitation team lead, obstetric consultant, and the anesthetist. And once the patient is declared dead, then obviously CPR will be stopped and all the instruments and everything will be left in place. Coroner will be informed about the death, and everything will be left in place for the postmortem examination point of view. And then now this obviously can be quite a traumatic experience for the team involved and the other staff in the delivery suite. So you will have a team brief again to see what went well, what could have been done differently, and also to support provide the support to all the staff. Then you need to debrief and provide the support to the relatives as well, and you will arrange bereavement counseling for them. This death will be reported to maternal mortality register, and again here will also be risk incidence form will be completed for the detailed analysis to see if there was anything which could have been done differently, or we could have done anything to prevent this death. And the lessons will be learned and applied in the practice. Okay, so this is what, and then obviously there will be a detailed and comprehensive documentation into the notes according to the time. Right, so that's how you do.
Hello, Dr. Sophia.
Yes.
We will not mention regarding the medicine, adrenaline, and all these things, correct?
No, it's just the algorithm you need to find, just that's what we need to just listen is kind of, again, like animal, animal thing we do, so that everybody knows it by reflexes what to do. But yes, in the structured discussion, you can be asked. So you need to have an idea. But when you are doing this, you are saying this, going through this algorithm, you don't need to talk about the medication. As long as you are saying we will be thinking about the reversible causes and then do, because when the resuscitation team arrives, they are going to do those medication and stuff. So you won't be doing that. You're telling what you need to proceed. But yes, for the structured discussion, you need to know those medication and what to give when, if being asked from the examiner, or if you have actually completed the station, which you usually will do in this particular one. They usually get finished in about 6-7 minutes. Then you can just mention to the examiner to say, so I can tell, according to the what, when we will be giving what, then you can tell yourself as well.
Okay. Thank you,
Ma'am, do we need to tell about per abdomen, per vaginal examination here? History of tightening, abruption, or any scar rupture? to see for
No,
vaginal.
you need to just say, no, you can't waste your time in all that stuff. You just need to say what I have said and the way I have said, okay?
Yes.
Unless then the examiner, after that, the examiner initiates some discussion, then obviously deal it according to the questions being asked and according to the discussion. Otherwise, this is a fixed, the algorithm you need to follow. Right, who is next?
Reena Kumari.
Reena? Hello, Reena, are you with us?
Next is Selena.
Selena? Hello, Selena. Yeah, Selena.
Yes, good
Yeah,
morning. I'm
Selena.
here. Yeah. Yes, I'm here.
Good
Good morning.
morning, Selena. We miss you a lot as well. We don't see you quite frequent.
Sorry, I sometimes had on calls. Sorry.
It's fine. I understand. In obviously, August is a shift over time. So, okay, right then. So this is for you. And when you have read this, you can tell me. I will show you the CTG trace as well. Everybody else, please, mics off. Sarujna, your mic needs to go off. Good. Thank you.
So should I start?
You take your 2 minutes to organize, write down your bullet points, what and how are you going to talk. So this is the CTG trace. You can have a look on that as well. Oops.
Excuse me, ma'am, for last questions that maternal collapse, you were telling 30:2, it's not required till that obstetric resuscitation team comes, continuous chest compressions and then oxygen by the midwife, continuous oxygen flow. We should not tell about 30:2, 30 compressions and 2 puffs of the oxygen.
Okay, so no, it's not to puff of the oxygen. When we are in the room, we can just put, because there has been a little bit of amendment in that 2 breaths. Sometime, if you don't feel safe, you don't even have to give the breath. You can continue just with the chest compressions. And recently, because of this COVID and everything, it's like, you can say, that's why we said, like, because we are in the room, we will just start giving that oxygen with the mask. But if not, then yes, it's 30:2.
Compressions, and if oxygen supply is available, then continuous oxygen. Like that we have to tell.
Yeah.
Okay. Thank you.
Should I start?
Can, if you feel ready.
Yeah. So hi, it's
So this
Selena.
is the CTG place, yeah?
Yeah, I saw it. So hi, Selena. I'm the on-call register today in the labor ward, and you?
Hello, my name is Jade Mollay.
Okay, Jade. Nice to meet you. I understand that you are the new ST1 trainee in our unit. Is that right?
Yeah, doctor. Well, I have been Selena like about two months now.
Okay.
Yeah.
Okay. So I think everything is going okay for you.
Yeah, it's pretty good. Yeah, thank you.
Okay. So Jade, do you have any concern?
Yes, Selena. I was asked by the midwives called me to have a look on the CTG of this lady. And you know, I have seen, but to be honest, I don't exactly know what to do with this really. Because you know, I'm a GP trainee and I'm just trying. You know, I know some basics about the CTG, but I really don't know what to do with this one. So I wondered if you could come and see me, you know, see this lady and tell me what to do with her.
Okay, no worries, Jade. It's perfectly all right. I am here to help you. So can we go to the patient and then we discuss about the patient? Is that okay?
Yeah, that's absolutely okay.
Okay, so I understand that this patient is a primary gravida and she's in spontaneous labor and that she is 40 weeks pregnant. Am I right?
That's right, doctor. Yeah, she's primary with 40 weeks. Yeah, she's in
So
spontaneous labor.
okay, so when the midwife asks you to review the CTG, have you taken a history or seen her notes?
Yes, I have seen her notes. I mean, she's low risk. Otherwise, I haven't seen any complications or risks being defined there now.
Okay, so you have the search about her risk factor. That's fine. Excellent. So you told me that you are GP trainee. Have you ever had a training or any learning about knowledge about CTG?
Yes, I had. You know, when we had that you know, that teaching session on CTG.
Okay, so it's all right. So Jade, what we will do, I will again check her notes and see whether there is any risk factor present. And she was admitted with spontaneous labor. Just I will ask the midwife how far, what is her findings, examination finding, like whether the patient feels well, she is happy with her baby's movement, and when was the last examination, internal examination was done, and how far dilated she is, and what is the position and station of the baby. And then I will teach you to review the CTG. Is that okay?
Yeah, that's okay. So the midwife told me she's just examined the lady and she's about 5 to 6 centimeters dilated, and she said the head was like you know, at the spines, I think she said. Yeah.
Okay, so Jade, to explain CTG, we always follow a mnemonic called Dr. C Bravado. So doctor means defined risk. So from your history and for the note, I can find she's low risk, and also C means contraction. So where we see the contraction, we see the contraction in the lower part of the CTG sheet. Can you see it?
Yeah.
Okay, and we always count the contraction between 10 minutes. So if you see this two line where there are some number in between this, we see that there is 2 to 3 contraction in 10 minutes. Can you understand
Yeah.
it?
Yeah, that's right. Yes, that's right. Yeah.
Okay, and then we have to see what is the baseline heart rate. That is the fetal heart rate we are all monitoring here. So baseline heart rate is the straight line you are seeing, and it is almost a little bit below the 180. And do you know about the normal baseline heart rate?
Yes, I think it should be 110 to 140, I think.
Okay, that's brilliant and perfect. Yes, and what we are seeing, it's above 160. So that is a abnormal feature here. And then what about, do you have any idea about the variability? Do you know what variability
No,
is?
I forgot. I
Oh,
forgot about variability.
no worries, it's perfectly all right. Just variability is that what is the fluctuation between two beats. So if you see a normal CTG, I will show you after this. you will see that the variability is always more than 5. That is the difference between two beats is always 5, the fluctuation. So here what we see, the variability is almost nil. That is a straight line. Can you understand that?
Yeah, that's right. Yeah.
And there is another thing, that is acceleration. That means that baby is active and happy. And here we don't see any acceleration. Do you know what is acceleration is?
So acceleration is like when it goes above the baseline,
Excellent.
like make some, you know,
It's
some spike
usually
there.
what it goes to 15 beats above the baseline, and it lasts for 15 seconds. You know almost everything. That's good. And then we see the deceleration. Deceleration is downward. Acceleration it will always go upward of this line, and deceleration is the same decrease in 15 beats for 15 seconds down the line. So we are seeing that here are few deceleration. And this is called variable deceleration. There are a few types of deceleration. We always define them in contrast to contraction, uterine contraction. So if it just correspond with the contraction, we call early deceleration, and we are not that much concerned about it because it happened due to head compression. But there are a few deceleration, but we have to monitor that how long they are persisting. So according to this CTG, it shows that it is abnormal CTG because there is two concerning feature, because her fetal heart rate is above 160, and also there is no variability, and we get quite concerned when variability are like this. Do you understand?
Yes, doctor.
Okay, that's great. So what we will have to do, we now have to again see that whether the patient is well. So what I have to do, though you have asked that the midwife has recently examined her, but as there is a concerning abnormal CTG, I have to examine the patient. What is the idea between it? When I do the digital examination, sometimes what happens, the baby respond by acceleration, then we get happy that the baby is okay. So I need to again assess the patient doing upper abdominal and internal examination. If I don't find that on my examination the CTG is become reactive, we see it reactive and we see acceleration, then we have to do some further intervention. Is that are you following me?
Yes, doctor, I'm following you.
Okay.
So what
So
interventions we will be doing?
okay, because you told me that when the exam midwife has last examined it, it's 5 to 6 centimeter. So we can do a procedure called fetal blood sampling. What we do, a fetal blood sampling, we take a little bit of blood from the baby's scalp by a procedure called fetal blood sampling that I explain you in a minute, and then we check the acidity of the baby's blood. And there is a specific range. If the baby's blood is within that range, we become happy that baby is okay, and we also follow it by CTG. Am I make any sense?
Yeah, okay. So how we interpret the fetal blood sampling result then?
Yes, that's good. And then what? So what I will do now, I will just do an internal examination just to see that whether baby react by having a acceleration. If that doesn't happen, then I will request the midwife to arrange the fetal blood sampling machine and the fetal blood sampling set, and then I will ask to keep the I have forgotten the name. The machine where we measure the sampling, fetal blood sampling, and then I will take the fetal blood sample. There are a few contraindication to it, but as she is a term pregnancy, we can do it. And after the fetal blood sampling, if we see that it is within normal level, then we will just follow up the CTG. But if there is any concerning feature or the CTG remain same, then we have to repeat it in 30 minutes time. And if that doesn't improve, then we have to, because since think about the category 2 cesarean section. Do you know what is category 2 cesarean section?
No, I mean, yeah, I know that one is like we need to do this, but what are the normal levels of their fetal blood sampling, doctor?
Okay, if we find between 7.21 to 7.5, then we are happy that her baby's blood acid level is okay. But we have to closely monitor both things. We can't just depend on that. We have to see how the patient is doing, how the CTG is. If it is not within normal range, then we have to repeat it in without 30 minutes. And if thus doesn't happen and the CTG more deteriorate within time, then we have to counsel the patient and take consent for category 2 cesarean section. Am I make sense?
Yes, doctor, that is.
Okay, so Jade, it's very difficult because CTG, as you see more of the trace, you will become more familiar. So today it's an emergency situation. In other time, when I'm in the labor ward, you can come and I can teach you everything in detail. Is that okay?
Yeah, that's absolutely fine, doctor. Thank you.
Okay, so you, okay, thank you.
Thank you very much, Selena. That was very good. Really good.
Thank you.
Okay, so just a couple of things to just imagine how we do. So this colleague, I will when you address the colleagues, even if she's a new trainee, she is on call with you today, so you know the name, yeah? Who is your trainee? Who is your other ST1 who is working with you? So when you go in, address the trainee with the name Jade. Hello, Jade Male. I'm Selena. You can give your name, full name again. And then you can say, okay, so just naturally just start by saying, so how you been doing? How is everything? Are you settling in the unit? Any problems, any issues at all? Just these couple of social sentences. And then you can start, or she might just start before you ask her, yes, thank you, this and this. And then she says, the midwife called me to have a look on the CTG. So I just brought it to you. So you're going to have a look on the CTG. If it's a normal CTG, so as we know, this is abnormal CTG. So that's the right thing to do immediately. The first thing you need to say is to say, this CTG is abnormal, so we need to, and this patient is in labor, and so we need to actually immediately go to the patient so we can start some intervention. At the same time, I will explain you how to interpret the CTG. Yeah. So that was good to say, and then you will say, so, and what we need to do is, we can go there, ask the midwife to put the patient to left lateral position and start some fluids. And then, we will need to do fetal blood sampling, so we can ask her to get ready for that as well. And then you can start by saying, right, so yes, just establish your knowledge to say, how much you know about the CTG, and about the components of the CTG. So instead of individually asking every stage, you just see what she knows, acceleration, decelerations, whatever. Just ask that once. And then, yes, you start the way you started on mnemonic, just on DRC Bravo, and then define what that is. And when you say define risk, then you need to ask, like, have you reviewed the notes? Have you spoken to the midwife and to the patient? Does this patient have any risk factor in the pregnancy, like any maternal or fetal complications, like the mother have anything like preeclampsia or diabetes or any other complication? And about the baby is like, the placenta, obviously if she's induced and labor, placenta must be in the right place anyway. So, okay, so have there been any concern about the growth of the baby or baby well-being? Okay, so that's about the, it's not only you telling her, you need to also make sure, because you're going to take action on this CTG. So you need to know as well by asking from her, have you seen this? Is there any of these present? And then if she says no, then you say, okay, so the next one is then to, to assess her to the abdominal and that examination to, get an idea how far she's in the labor. And then, the cervical dilatation station, as you said, so she tells you this is what it is. And then you can start, explaining her to the CTG. And then you can say, okay, so that's good. If she's 5 to 6 centimeter dilated, that means we can actually do fetal blood sampling. So I will explain to you in a minute what fetal blood sampling and how we do it. So let me explain you the CTG meanwhile, how we interpret this. And then the way you did that was fantastic. Yes, tell about the, what these, boxes mean, what distance of 1 centimeter per minute and 10 minutes between 2 marked lines. And then, the baseline, I won't go into that detail again. That was nicely done. You did nicely explain her. So the only one thing for the variability, you said it is always more than 5 beats or byte. No, we don't say it's always. We say the normal variability should be from 5 to 25. This should oscillate between these between these horizontal boxes here. And you can just with the cursor tell to the patient if it's online, and if you're sitting there, obviously you can just tell with the help of some pen in your hand. And then yes, the acceleration, decelerations you define, and then you say like, okay, so regarding the acceleration, because they're early accelerations, the deceleration, sorry, and they only mean a pressure on the head, and most of the time when we put the patient to left lateral position, that relieves their pressure, and that can improve the CTG. However, as you said, like this patient has just been examined, and after that, if there hasn't been any acceleration, so we don't need to, well, we will be examining her because we are going to do fetal blood sampling. We're not going to examine just to see whether the CTG shows any accelerations. We know this CTG, even if it shows one acceleration, we're still going to do fetal blood sampling because this is abnormal CTG now, yeah? So yeah, so then you will say, so we go there. So after explaining that, so then we need to go the fetal blood sampling. The fetal blood sampling, what we do actually, we just take a, you know, the very small amount of blood from the skin of the scalp of the baby. And you know, I will explain you that procedure when I do that. We don't need to go into the detail how we are going to do that, but you basically just explain, like, you know, explain when I take you through when I'm doing that procedure. And then we will take their sample, tell the contraindications and indications. So contraindications, you know, these if the fetus has these, then we wouldn't do that because that can obviously cause to hematoma or bleeding. And then there's gas analyzer, yeah, the machine we read that in. So you will say, so we'll take their blood like in 3 small capillaries, and then the midwife will analyze that in the gas analyzer machine we have on the delivery suite. And then our further decision will depend what are the results of the fetal blood sampling, and just tell what they are, right? So we will define it according to the pH we find. So pH of 2.5 and above is normal. So if the result is, you know, this, there is pH is more than 2.5 or 2.5 and above, then we can leave this patient to continue for 1 more hour. 60 minutes with the normal one, yeah, and then we will observe during that without making those conservative measures as well, like left lateral, giving her some fluids. And if CTG improve, then it's fine. We will just continue with the monitoring of the progress of labor. But if the CTG remains same within that 60 minutes, then obviously we will be repeating fetal blood sampling after 60 minutes again. And obviously, if we deteriorate in a way that we start having very deep decelerations or bradycardia, then obviously we will need to take action accordingly at that stage then. If the pH is from 7.2 to 7.25, we call it borderline. In that case as well, we can leave the women, but only for 30 minutes to see if CTG improves, that's fine. If not, then we're going to repeat fetal blood sampling after 30 minutes. And if the pH is below 7.2, then we will need to proceed to deliver this woman. You know, there will be category 2 cesarean section. Category 2 cesarean section means we need to deliver this woman between, you know, 60 minutes. We will need to do that cesarean section. And then once the baby is born, we will be taking blood from the cord of the baby as well to check for the gases levels in the baby's blood. All right. And then you will say, okay, so, and then the rest was fine to say. So what I will do then after that, we will have that, you know, those some more, you know, when we are a bit light during the day in our shift, or maybe sometime afterwards, I will pull out some CTGs from the CTG teaching, you know, that file. And then we will just go through different type of CTGs, how the normal looks like and how the various abnormal features look like. And then you can recommend her as well to say labor ward manual, you can see from there as well. And then, you know, from the NICE guideline as well, you can just read from there as well. These are the resources. And then just check with her to say, you know, are you happy with this plan? Right, the next one.
Hello, Dr. Sophia.
Yeah.
When the CTG is like this, and if the fetal blood sampling also come supposed to 7.2, then it will be category 1 or it will be category 2 cesarean section?
Okay, so category 1 is to deliver the baby within 30 minutes, and that's done only in 2 circumstances: when there is an imminent threat to the life of the baby and the mother. And in imminent threat to the baby is defined as the only one condition when the bradycardia is more than 3 minutes. Okay, so that's the bradycardia when there is a late one. So that's the only condition. And the mother is obviously, you know, it can't be anything when the mother is deteriorating. It's not stabilized because we need to keep a balance between the safety of the procedure as well as between the well-being of the fetus. So that's what. So that will be category 2. Category 1 is only fetal bradycardia.
Okay. Okay. Thank you, Dr. Safia, for clarification.
You're welcome. Who is the next one, Pramila?
Shazia.
Shazia?
Yes, Dr. Safia, I'm here.
This is for you.
Okay.
That's your first 2 minutes. You can start.
I am Dr. Shazia, one of the candidates for the MRCOG Part 3 exam, and I am here to go for the structured discussion for this case. So in order to proceed,
Tell us how you will proceed.
yes. So in order to proceed, I want to use the S-bar tool to proceed this structured discussion. And the situation is this, that I have a patient that is Demi Ford, 36 years of old, in her first pregnancy, and she conceived with the IVF, and currently she is now 29 weeks of pregnancy. And she admitted in the labor ward, it's not written, she admitted since 1 hour with a history of tightening. So in the background knowledge, I want some information about her course of the journey of the pregnancy up till now. I will review her notes and I will check any investigation up till now she has been gone through, all the scan reports, and whether the baby growth is okay or not up till now. And then I will ask some history from the patient about this pain. Since how long she has this pain? Is she progressive in nature? And whether this pain is associated with any bleeding, any watery vaginal discharge, or does she have any fever, any urinary tract symptom like burning micturition, and anything else? And does she have any cough, sore throat, any shortness of breath? And all these history points will be according to the differential diagnosis of this patient, as she is currently 29 weeks with the tightening. So the she might be with a threatened preterm. There may be, as the IVF pregnancy have more complications, there may be chances of abruption. So I also looked keenly for the record of the blood pressure in each antenatal visit up till now. And there may be urinary tract infection. There might be some domestic abuse, and these things I will keep in mind, and I will ask the questions to evaluate and rule out the causes of these problem. Then I will ask my midwife to check her vitals, including her blood pressure, pulse, and temperature, and I will assess her BMI, and I will examine her from the tummy, and I will just assess her the height of the fundus, and to know that whether the height of the fundus is according to her gestational age. And then I will assess the presentation and lie of the baby, and I will go for the assessment of the uterine contraction for the 10 minutes, and I will look for the any tenderness to rule out the abruption also. Then I will ask the permission from the patient to go for the sterile speculum examination, in which I will look for the any discharge, any watery vaginal discharge, or any copious infected discharge. Then I will take some swabs for the infection, and keeping in mind if that she might be in the threatened preterm, so I will take the swab for the fetal fibronectin also, and I will assess the dilatation of the cervix and the length of the cervix also by this speculum examination. If I have, do I have these informations available? And I will also ask my midwife to attach the CTG so that I can assess the fetal well-being. Do I know the investigation, if anything, available up till now?
Yeah.
So the information that have been provided to me, according to that, she has in a preterm labor, and there is no problem up till now in this pregnancy. All the screenings were normal up till now, and she has contraction for the last 2 hours, and they are regular 1 to 2 in 10 minutes. So she is in the early mild contractions, and there is no tenderness, so the abruption is ruled out. CTG is also okay, and there is on the speculum there is no liquor. So now, and the urine is showing that there is infection, and that is sensitive to the penicillin. So for this information that have been given to me, so this might be the urinary tract infection, and she is underwent the threatened preterm labor, as the source is also not dilated, and there is no bleeding also. So we will treat on this line, and I will ask my midwife to start the tocolysis, and tocolysis that can be with the atosiban or nifedipine, if according to the policy of the unit. Meanwhile, I will also ask to give penicillin, and I will again confirm if there is any allergy to the penicillin, if the patient is any allergic to the penicillin or not. And midwife will give the penicillin after the sensitivity dose. And in order to keep these things in mind, that patient is in at 29 weeks, and there might be severe, if the baby will deliver, then this is severe premature. So we will I will ask my nurse to give a steroid injection, that would be dexamethasone 12 milligram, 2 doses, 24 or 12 hours apart. And as the fetal fibronectin is also showing positive, so there might increase chances that the patient will be delivered. So I will also start magnesium sulfate with the 4 gram loading dose, and then I will maintain it with the 1 gram per hour for next 24 hours. This helps in the neuroprotection of the baby, and the steroid injection will help to help in the maturity of the lungs, and most of the complications of the severe prematurity, like difficulty in breathing, RDS, and these will be protected. These will be prevented later on once the baby is delivered. And my plan is this, that I will inform my consultant about this patient, all the details and whatever the treatment I have given to the patient. I will inform my neonatology consultant also that there will be my delivery is expected for at 29 weeks in the next 24 hours or more. So they will get preparation, and I will ask my coordinator midwife to ask the availability of the cot in the neonatal intensive care unit. I will again explain everything to the patient also, that this is the current condition that we are facing, and we are giving all the medicines to you to prevent your delivery, and we are trying our best that the dexamethasone doses and then magnesium sulfate will be completed before.
Okay, so
If there is
Shazia, I will interrupt you here. So there is no cot available on your unit. So
okay,
how will you proceed now?
Okay, so I will inform my consultant that we don't have the cot in our neonatal intensive care unit. I will ask my midwife to look for the availability of the cot in any neighboring neonatal unit, and then I will make the transfer of the baby in utero. I will inform the patient about all the process we are going through. I will ask the senior midwife who is trained to resuscitate the premature baby if there is a chance that the baby will deliver during her transfer. I will arrange the resuscitation trolley and all the arrangements in case the delivery has been happened in the ambulance along with the medicines.
Right. So how are you going to give this handover to the neighboring unit? So you make a call to your registrar in the neighboring unit.
I will call the neighboring neonatal unit also, and I will talk to them, and I will inform that, hey, I am Dr. Shazia, and here with us there is 29 weeks pregnancy, conceived with the IVF, and she is currently in the threatened preterm labor. Unfortunately, we don't have the cot, so we will transfer this patient in utero, and we have given this medicines up till now. All the written information, I will handing over to the midwife, and I'm going to fix all the information about the investigation and all the treatment that we have given up till now. I will also talk to the obstetric doctor in the neighboring unit also and inform about everything that we have done up until now, and I will explain the patient also, and I will make sure everything is ready so that we will transfer the patient to the neighboring unit. But before transfer, I will ask my midwife to examine the patient again and inform me so that the patient will be ready to go.
Okay, so when you examine, the lady is 6 centimeters, she's more regular contractions now. So what we're doing now?
Okay, so she is now 6 centimeter, and so I will ask my midwife to monitor the contraction, how much she is contracting currently, and I will inform my consultant that. And I will go for the assessment of if there is any watery vaginal discharge or not, so that and I will rule out if there is watery vaginal discharge. So I will check for the cord prolapse. I will attach the CTG continuously. I will inform my consultant that we are not going to transfer this patient anymore to the neighboring unit because the patient is now in active labor, and we will deliver the patient and we will keep her here, and I will talk to the neonatology doctor also, and I will inform them. Previously we were going to transfer this baby in utero, but now we need to resuscitate this baby and decide after the delivery whether this baby will be fine or we need to transfer the baby after the delivery. Meanwhile, I will arrange or make all the arrangements for the delivery, and once the baby will be delivered, then I will hand it over to the neonatology doctor. And what?
Okay, so baby is born with a good Apgar score, good cry, and your pediatric colleague phase is okay and safe to leave the baby with the mother.
So the baby is good. That is very nice. And I will congratulate the mother. And but regarding the decision of the peds doctor that the baby will be with the mother, I will have a concern reservations for these decisions. So I will talk to the pediatric doctor again, that keeping in mind the severe prematurity as the baby is at 29 weeks and she baby is only received a single dose of the dexamethasone until now. So there is might be chances that baby is currently okay, but she or he may develop hypothermia, hypoglycemia, or all the complications of the severe prematurity. And I will explain that for my understanding that the baby should be under observation in the neonatal unit for the close monitoring until that we are sure that the baby is quite okay. So if the doctor is agreed on my concern, that is very good. Otherwise, I will talk to my consultant and I will talk to the neonatology consultant also and show my reservations about the keeping the baby with the mother.
Yeah, that's fine. Thank you, Shazia. That was very good. Yeah, I love it when you have really listened the recordings and then you have really prepared.
Thank you so
Memorize
much,
everything.
Sapriya.
Good, good. So yeah, so for everybody, you need to listen to these recordings again and again and again. Write your points till you actually start regurgitating the stuff which we have said in the recording. So that was excellent. So yeah, so in structured discussions, this is how you need to start, summarize, and then you will start saying, and then you need to say, I need to have more information. And the information will be categorized in two parts. One will be about the complaint or the incident she has come in, like we will like to know about this woman. First you need to ask about when she started, these contractions, if she had any, has she noticed any watery leakage, and any bleeding down there, any history of dysuria, all the possible causes which could take it to preterm, any overall illness, anything she has, any history of abnormal vaginal discharge, any chest symptoms, and all that history you will include. So that's about that incidence, and have the contractions been becoming more regular or increased, or they are fading out. I will also ask about the movements of the baby. Then you need to go a background information about the pregnancy, which will be like, you need to then say, like, I would like to also make sure, are there any other complications in this pregnancy, maternal or fetal complications? Like, I would like to know about the position of the placenta, 20 week scan details, and any concerns about the growth of the baby, or any other complications mother has, like preeclampsia, diabetes, or any other maternal complications. So because the colleague to colleague, as soon as you say maternal complications and fetal complications, it's understood that you want to exclude every risk factor here. And then yes, the generalized history of the women, any other health conditions, medication, her VTE assessment, like our BMI, and history, yeah. So then you will go to your examination. So take up to the investigation, unless she gives you the card beforehand. Otherwise, go up to there and then ask, can I have the information about that as you did? So examination will be, and when you're talking about the examination, tell why. Yeah. So I wouldn't say particularly, I will ask my midwife to do this and this. I mean, it's okay if you want to say that, but just simply say we check her, pulse pressure and temperature to exclude any tachycardia and any, pyrexia. And then abdominal examination. Abdominal examination is, yes, you will, make sure the fundal height corresponds to the date, lie of the baby, presentation of the baby, contractions for palpation of contractions for 10 minutes, and I will exclude any uterine tenderness. Now, uterine tenderness is not only because of the abruption, it's also because of the choriamnitis we want to know. So, to exclude that one. And then, yes, you will proceed to spectrum examination. And spectrum examination, what we're going to see, any pool of, any watery pool, a liquor pool, any abnormal or offensive discharge, and, any bleeding there, is this cervix, the os has started dilating a lot. So that will be done, and then you will say for the cervical length we can't assess just on the spectrum examination. So that will be done like if we have the facility of scan on the labor suite, then we will do transvaginal scan to measure the length of the cervix. If not, then obviously we will proceed for the fibronectin test, and the urine for urine analysis to exclude any proteins and also any leukocytes. And then, so before actually you will start the examinations, you need to say to the woman that I will counsel the woman to say, we are suspecting that she might be going into early labor. So I will explain that I need to do these examinations to get an idea. Okay, so once you have completed your examination, then you will ask the examiner if I have the information. Then you are given the information which shows she's in the labor. So again, for that one, you need to again start from the counseling of the patient first. Yeah. So the first important thing which will come will be to counsel the patient, to inform that it appears like that there is a possibility she might go into labor and deliver within next 24 hours. And then there is also infection in the urine, for which we need to give her antibiotics. So we will check, rule out the allergy to penicillin and start her on antibiotics. And then yes, so then you will say basically the counseling of the women, and then you will keep talking about what we're going to do. Yeah, so you will say like I will explain her like in the premature birth, these babies can be at risk of breathing difficulties, respiratory distress syndrome, high risk of infections. There can be small risk of neonatal death as well, and then learning difficulties. So to try to reduce these risks, I will discuss and offer the women to have, the steroids, dexamethasone for the lung maturity, and then you can tell the dose. And I will also discuss, and if she's happy, I will start with the magnesium sulfate, and then you can tell about the magnesium sulfate for the neuroprotection and the possible doses. Then the next thing it comes is like you're going to say that I will also then speak to the pediatric registrar, and I will request them to come down and speak to the women to explain her about the possible fetal outcomes or any risks the babies can have at this premature birth. And then I will also check for the presence of any cards. Is there any card available in the NICU? And then, yes, after that, you're going to inform your consultant about the admission and this tuberculosis. You will start the tuberculosis. Now, tuberculosis as well, you need to have an idea about the how we do with the nifedipine and etoxaban doses, because it's again clinical discussion. You can ask you. And don't say according to the unit policy. You need to act according to your unit. So, it's usually nifedipine. So you need to just say, I will start with the nifedipine. Like this, unless there is any contraindication, which obviously should have come in the history card if there was any. And then you will say, and then you examine, you inform and then you are told there is no card. So, okay, so if there is no card, that means we need to now transfer this woman, we need to make this in utero transfer. And then, yes, your coordinator midwife needs to check for the availability of the card, enabling units, and then you're going to inform your consultant as well that we need to transfer this women because we don't have the available card available. And then you are told there is usually a phone there. They ask you actually to pick up the phone and make a call, and there is a person on the other side as well. And there's a standard way. Again, this is the importance of the handover. Like you follow the S bar again. So you're going to say, hello, my name is this and this. Thank you very much for accepting our this lady, primi gravida, 36 weeks or whatever, this week's pregnant. Just literally as we kind of present as a student, she presented with 2 hours of contractions, and now we have examined, there is no rupture membrane, or there is a rupture membrane, fibronectin is positive, and we have started the tocolysis with this, name the medicine. We have also started the steroid, first dose has been given. We have also started the magnesium sulfate infusion. And the patient has been counseled and informed. We have discussed about the neonatal morbidity. And then you need to say, so I will be, we are making arrangements for the transfer. She will be accompanied with one of our senior midwives who is trained in the resuscitation of preterm babies. I will also fax the notes of the women, and then the midwife will have the copy of the notes with her as well. And once we have the results of those investigations, whatever you have sent, the swab or blood test, whatever, we will give you, we will pass on that information to you as well. And then, yes, then you go further and proceed and say, so once arrangements are complete, we will, transfer the woman, and we will examine the woman just before the transfer, just to ensure that she's not in active labor. So then you were told she's 6 centimeters dilated. That was fine from there. Then that obviously we need to, it's not safe to transfer her in active labor now. So we will deliver her and then transfer the baby. you will inform your consultant about the change in plan. You will speak to the pediatric registrar again as well, that we need to deliver and resuscitate this baby, stabilize it, and then transfer. So then you are given the information, baby is delivered, and the registrar feel it's absolutely okay to leave the baby with the mother. Now, these things are not there just to make it a funny or lengthen the scenario. There are reasons. There are certain skills being checked here. About the safety, about the communication, sometime about to take the responsibility. Your colleague may not be thinking straight at that time, but you can't just think about thinking, okay, because it's a baby and it's a neonatal registrar, that's his responsibility to think whatever he says. No, you being a clinician also have a knowledge. So sometimes you need to recommend to your colleague, which you might feel he's not taking the right decision, maybe right approach for the safety of the patient. And that's the reason they added that little bit in the exam by saying, okay, he feels you can leave the baby. And then you will say, well, I will discuss with the registrar to say that I do have some concerns, because although baby is born with a very good Apgar's curve, obviously there is a risk of hypothermia, infection, and all those. So the best plan will be to transfer this baby to the neighboring unit with the mother. And if he's happy, that's fine. You continue with your plan, and if not, then you're going to give ring to your consultant and just discuss and express your concerns before you actually transfer the patient. And at this stage, if you are asked like, okay, so your consultant also feels it's fine to leave the child with the mother, that's absolutely fine for us now then, yeah, because he's your supervisor, he's your clinical. If he feels it's okay, then yes, you can just leave, yeah. Or on the other side as well, if it was a pediatric consultant, but you still will inform to your consultant about the plan. So this is about the safety ladder, that if you have any doubts about anything, express them and then speak to your next level of seniority to get an advice or opinion. Okay, who is next?
Doctor, one question, doctor. If patient is allergic to penicillin, so how to address that concern for UTI? Do we supposed to do desensitization and give, or we have to directly switch over to some other drug? Usually what drug we are giving for UTI?
So nitrofurantoin is safe in pregnancy, that can be given. And if there is an allergy, then there will be some other sensitivities given, or you can speak to microbiologist.
Here we can say that we will send the urine culture and we will follow the advice of microbiologist.
The urine culture, well, that says sensitive to, when it says sensitive to Staph aureus, that means urine culture has been done already. Okay. So another culture, there are like 4 or 5 medicines they have given according to the sensitivity. There is not just a single one. So we will see if what's the other option given there safely, which we can give. And otherwise you will speak to the microbiologist.
So in exam,
the answer is you will check the rest of the sensitivities on the culture report, and then give which one is safe in the pregnancy.
Okay.
Hello, Dr. Sophia.
Yeah.
Is there any restriction to, if we will transfer the patient in utero, is there any restriction to particular tocolytic? Because in one trust guideline, this I saw, it is written GTN, we will give GTN patch. Is there any restriction if we will give nifedipine or atosiban while in utero transfer?
No. So you don't need to look at individual trust guidelines or papers, because sometimes those papers people are sharing, they might be just some old, and there might be some other reason for that, why they particularly said something about. So all you need to follow is the NICE and the RCG and TOG guidelines.
So means we will not say only GTN we will give, because that was I might give fine. Okay, so we can give nifedipine or atosiban.
Yeah, just check in the guideline what's written in the NICE guideline, what's written in RCG guidelines. If it's not given there, you don't need to talk about that. at all.
And one thing more, Dr. Confusion, because of might be that trust guideline or what. So because they said okay, to give magnesium sulfate when patient is in active labor. Is that right? Or in this condition, like she is 2 centimeter, we can give magnesium sulfate for
Okay,
neuroprotection?
so the magnesium sulfate is not that when the patient is in active labor. The magnesium sulfate is given when there is imminent labor, when the patient is in imminent labor. And when we do if we say fibronectin test is positive, that means the labor is imminent in next 24 hours. All right.
Okay.
So you will start the magnesium sulfate.
Okay. And then GBS prophylaxis also we will start or not? That will be in active labor.
That will be yeah, that will be in the labor.
That will be means after 4 centimeter dilatation, we can say.
Yeah.
Okay. Okay. Thank you, Dr. Safia, because that was confusion.
No, it's absolutely fine. It's absolutely fine. But be careful. Please do not say anything which you see from the, any documents being shared other than RCG, and do not complicate and put yourself in trouble anyway. Keep it simple, just simple, They don't the exam. We don't want you to go these type of like try to prove you're technically so much in depth and I don't know what. You're ST5 at this stage. You're expected to follow the guidelines and the NICE RCOG, and then if you're not sure about anything, just simply say I'm going to speak to my consultant and get this information. Just feel that these are the process check. This is not about to check like how clever you are to dive in this way to just to show something really different. Okay, so yes, do not follow anything from the random papers.
Doctor, for lung maturity, they give betamethasone or dexamethasone, doctor? Usually, what is the drug they're commonly used for
What
lung
does the
maturity?
guideline says? What does the guideline say?
Betamethasone 12 milligram intramuscular 24
That's
hours
it then.
apart.
That's it. Sorry if I said dexamethasone. So that's a betamethasone.
Yeah, betamethasone.
Yeah.
So both we can say, huh? Okay.
Yeah, so the units may have their individual policies, right? Sometimes it's because of the cost, availability. But for you guys, a safer thing is to just say whatever is given in the guideline, right? So, DEXA and beta, they both can be given, but that will be on the unit individual policies as well, right? But as I said, like, you just say whatever the guideline says. So that's fine. Right, next one, please.
Ma'am, can we use fibronectin or this cervical length screening below 30 weeks, ma'am? NICE says from 30 and above.
Yes, it is. But then if we have like somebody just at the verge of 29 weeks, we need to get some idea about that as well. So when it says it can be used, that does not mean that actually you cannot and you should not. That means it's more reliable after. Before that, it may not be as reliable.
Okay. If it is around 26 or something like that, can we say that I suspect preterm and just go ahead, or
Yeah,
should I
that's
say?
extreme prematurity. Yes, for extreme prematurity.
Okay.
I mean, cervical length by the by the scan. If we are doing that for cervical incompetence at the 8 weeks of 16 weeks, then I don't see any reason why we can't get that an extra piece of information and at 26 weeks. Yeah.
Okay.
When the guidelines say, they talk about the evidence behind, like when we can actually trust that from the evidence point of view, when it is more valid. So it may not be as reliable less than 30 weeks. It's more reliable after, but that doesn't mean you can't do it. Okay.
Okay. Thank you.
Next one,
Yeah,
please.
doing.
Ravina,
We are
please.
doing insulin like.
Yeah, sorry, say again.
We are using before 30 weeks insulin like growth factor to detect preterm labor.
No, that is for PPROM.
Yeah, sorry, mixing it. Sorry.
Okay. Go next person, please.
Next is actually Neelam. Is Neelam here? I didn't see her name. If Neelam is not there, then next is Anilasri.
Yeah, I'm Reena is here.
Oh, Reena Kumari has joined. Okay.
Yeah.
Yeah. Is it Reena next then?
Actually, Reena's name was called earlier. She was not there at that time.
Yeah,
So I
that's
think
fine. That's all right. This is for you, Reena.
Yeah, okay, thank you.
Okay, that's your first 2 minutes.
Okay. Hello, I am Dr. Reena Kumari, doctor in the antenatal care clinic today. May I confirm your name and age, please?
Yes, doctor. My name is Joe Ferguson. I'm 37 years old.
How would you like to be addressed?
You can call me Joe.
Joe. Joe, from your case notes, I understand that this is your third pregnancy. You are 36 weeks pregnant and you had a cesarean section followed by vaginal delivery. Today you are here to discuss about your delivery plan and you are requesting cesarean section. Is that right?
Yes, doctor. That's right.
And
This is my yes, third pregnancy.
anything else you want to add in this consultation?
No, that's all. I
Hello.
mean, midwife made my disappointment to come and discuss the mode of delivery because I want to book for a planned cesarean section, but she, she felt like I should consider the vaginal birth. But I don't really want to go try for the vaginal birth this time. I really had a bit bad experience last time, so I just want to have a planned cesarean this time.
I'm sorry about that. You had a bad experience. Uh, is it okay if I ask you a few questions to know more about your problem and what
Yes, of
happened in last delivery, and then we can discuss
yes,
about
doctor.
your plan?
Yes, of course, doctor.
Yeah, can you tell me what happened?
So the last delivery. I mean, I wanted to have epidural for the pain relief, because first time I had a planned cesarean section because I had a breech baby and opted for cesarean. So I was really, you know, terrified thinking of having labor pain. So the plan was I will have epidural, you know, as soon as I go into labor. But when I wanted to have the epidural, they couldn't get the anesthetist around, and I could not have that, you know, till, you know, quite late. So I mean, it was awful to go through all those. I mean, I use gas and air, but that doesn't seem to work at all for me. So that's one thing. So I don't want to really go through those pains again. And then my placenta was not delivering. So I ended up going to theatre anyway to have anesthesia again and have the. So I don't see any advantage of trying vaginal birth. You know, it's better to have a cesarean section, because last time I was up and about next morning and I was able to go home within 3 days. So yeah, that's what I'm here to discuss.
Joe, I'm sorry that happened with you, but every pregnancy experience is different from the previous. And you had a late epidural because maybe the anesthetic was busy. There is some situation and there are some priorities. Did they give any pathogen or any oxygen like nitric oxide, gas and air?
Yes, I had a gas and air, but it wasn't really working for me.
Yeah, okay. And I'm really sorry, but every experience is different from the other. So we will discuss about it. So can you tell me about this current pregnancy? What do you have, a boy or girl?
I'm having a girl this time.
Yeah, what name you give to the?
I haven't given the name yet.
Okay, so is she kicking well?
Yeah, I can feel the movement. Yeah.
Yeah. And how things are going in the pregnancy? Any problems so far?
No, there hasn't been any issues.
Okay,
It's
so
pretty straightforward pregnancy.
okay, so do you have any recent ultrasound?
Not a recent. I had the one done, you know, the 20 weeks.
Okay, was normal.
Yeah, that was normal.
Yeah. And what about the down screening, was normal?
Yeah, all tests I was told they all came back. Yeah,
Yeah, that's
normal.
good. Do you have any health issue for that following to your GP?
No, doctor, don't have any.
Okay. Do you have any, are you on any regular medication?
No, other than these pregnancy vitamins, no, I'm not taking anything else.
Okay. Do you have any allergies?
I am allergic to metronidazole.
Okay. I will write in the notes. And do you have any health issue in your family, like a clot, lung, or laying? Are you any type of this problem?
No, I never had any blood clots, no.
Okay. Not in your family as well. What do you do for a living?
I am a secretary in office.
Okay. Do you have enough support for upcoming baby?
Yeah,
Yeah, that's good. And everything okay at home?
yeah, all is
Yeah.
going all right, yeah.
Okay. You smoke?
No, I don't. I stopped smoking in pregnancies.
Okay. Drink alcohol?
No.
Use any recreational medication?
Oh, no, not at all.
Okay, that's good. Are you aware about height weight ratio?
Yes, so when I started pregnancy, it was 24,
Okay, what about your blood group?
O positive.
Okay. Thanks for information, Joe. From your history, and I can see you have a low risk factor and you can deliver a normal. So we will discuss about the mean. I can see you have a difficult vaginal delivery and not a good experience. So, Joe, I can reassure every pregnancy is different from other, and you had a cesarean section which was quite uneventful. So, Joe, when we had the first cesarean section, which is a normal. So, and I mean, less with the risk, but is when the cesarean section heals, and there are the some when it heals, it cause some scarring inside the womb. So I will make this picture. You look it. See, this is a womb. This is a bladder. This is a bowel, and these are the vessels. We put a cut on this womb and delivered the baby. And when this heal inside these bladder, sometime is stuck on the womb, and these are the bowel, these are the vessels. When we go
Yeah.
for the another section, so there is a risk of an injury on these areas. Am I clear so
Okay.
far? Do you have any questions?
Yeah.
And
Yeah, I am.
these things can cause the recovery delay.
All right.
And yeah, and may need to stay more in the hospital. And when we do the increased number of the cesarean section, so with the increased number of deliveries and cesarean section, this is the afterbirth. Can stuck in this operation site, which is a difficult to remove. And also sometime after birth come before the baby, and there's a life-threatening bleeding. So in that case, may require the blood transfusion and cause the more problem. And when the recovery is delay and in pregnancy, blood has the ability to become thick and produce the more put at a risk of the clot, and delayed recovery and delayed mobilization, it increase the risk of the clot lung and
Yeah.
leg, and which is also a life-threatening condition.
Yeah, I was informed these last time as well. Yeah, I
Yeah,
understand. Yeah.
so but these things are the number of the risk is increased more with the second cesarean section.
Yeah. Okay.
Yeah, so I can understand this is a time delivery, and you know it is a time delivery, and whenever you want you deliver. So,
Yeah, that's
but
fine.
there
That's
is
absolutely okay, doctor. I get this. I understand that as well. You know, that I was
yeah.
told all these
So
benefits of vaginal birth. That's why I chose to go for it last time. But as I said, like I just cannot think of going through all those pains
yeah,
again.
I can understand, and with the vaginal delivery, if you want to, because you had already you deliver. So I can understand you told about the epidural, but I can write again in the notes that when you go in the labor, they can give a early epidural.
Right. Okay. I mean, I
Yeah.
I I, I could consider trying the vaginal birth again if I can be really guaranteed that I will have the epidural when
We
I.
can't guarantee, but we can put in the priority that whenever you come and they can give you the epidural, because situation is depend upon the how is the situation of the labor was. But I can put in the special mark with the star, so they can note my point. I can highlight in this, so they cannot miss this.
They can't miss what, doctor? What?
To epidural, so I can highlight, but I can't promise, because when you came in the last time, they
Yeah.
were busy. The epidural was delayed. Anything cannot be promisable, but I will highlight in the notes. So whenever you come, they give you epidural.
Mm.
Okay. Do you have any question?
No.
Okay, so Ju, I want to ask you because you went with a difficult time and in the pregnancy there is a sometime the woman it is a quite common the women have a low mood, they are upset, depressed, and they are sometimes anxious each. Do you have a like this feeling?
No, doctor, I'm not feeling anxious or anything.
So
I'm
do you
okay,
have
thank you.
any question? Yeah, do you have any question so I can answer? I will give you patient information leaflet. So you
Mm-hmm.
read about the vaginal delivery, or if you want to know about the vaginal delivery, I can explain you more.
Yeah, no, I do know about the vaginal, but because I had it once, so
Yeah, you had that. That's why I will give you patient information leaflet about the cesarean section as well as the vaginal birth after cesarean section. You can read it again, and if you have any question and it is not needed to make a decision. You think once and you can discuss with your partner. I will arrange
yeah, no,
appointment with my
no, doctor, I think I feel I have made a decision. I would really like you to book me for planned cesarean section.
sorry. You want to go for?
Planned cesarean section.
Okay, so no worries. I will book you at a 39-week cesarean section, and I will give you appointment again, and I will give you the this consent form. You can read about it, and you can read this all this and sign it.
All right, doctor, thank you.
Okay, thank you very much for time, Joe.
Thank you, doctor.
Okay,
Okay, just in time.
sorry.
Just in time. Good.
Okay,
Time management was good. Right, okay. So when we consult the women for the mode of delivery, it can be, so we need to make sure that we stay very non-judgmental when we are giving that information. So we, about this variant section, I felt the information you're giving me was more about all the disadvantages of the variant section. And so I didn't hear about any possible benefit I can get from the intersection, and nothing about the vaginal birth either. No risk for the vaginal birth. All I was told was the good things about the vaginal birth. Yeah. So this can be quite not good. So we need to make sure when we say we give the information in a non-judgmental way, we want to make sure that the patient is fully informed. Although we feel, yes, if you go for a vaginal birth, that's the better. That's good for her because obviously reduces complications, mobility, everything. However, when I'm giving the information, I need to be completely non-biased in a way. Yes, we can say, we will recommend you this more safer option because of this is this. However, but we need to tell the risk with the vaginal birth as well. Then at the same time, and this is cesarean, if we're telling about all the risk, then we need to tell the benefits of cesarean as well, so she can make a full informed decision. Yeah.
yeah.
So
But I
the
asked
start.
her, so you want to know about the vaginal delivery? She said no. So I thought that's why I not give.
Yeah, because she is already overwhelmed. She has decided she wants to go for the cesarean, right? I had that discussion with the midwife as well. No, I have that feeling actually that you are going to actually make me to go for vaginal birth, and I'm not. So if you will ask me, do you want to have information about the vaginal birth? I'm going to say no, thank you. Book me for cesarean. All right. So no, you did well. You did well. I'm not
Yeah,
criticizing. I'm just giving the view, like when you're
yeah,
talking what
no,
you need
yeah,
to
I
know.
understand because these are helpful for us in the
Yeah,
exam.
yeah, that's right. Thank you. So you are quite empathetic as well. That you did say in the beginning to say, I'm sorry that you had to go through this painful experience, or this you didn't, have that your experience was not good. So to start with, yes, introduction, ask about, just open up first to say, so I understand you're 36 weeks pregnant and you're here because you want to discuss about the mode of delivery. So will you tell me what you want us to do for you? So let her open up. She gives you the story of first cesarean, then about the last time experience, what she has already. So just listen, because there's a lot of information you will get, and you won't waste any time. So the very first thing to do is to acknowledge that she actually went through the terrible experience, and you could say, "Oh, I'm sorry. It sounds really awful what you have been through." And then I can see, your reasoning to want to have a cesarean section this time. So when we say that, basically, we kind of win her trust and confidence in us that, we do acknowledge, yes, it is, and we are open. And then you can say, okay, so before actually I go into the details to discuss about, what you want us to do, can I ask you a few questions? And those questions are, yes, to ask about the current pregnancy, about, general things you asked, how has there been any problems, any health issues you have, high blood pressure, diabetes, anything. Was your scan going to be reported normal? Has there been any concerns about the growth of the baby or the well-being? Are you happy with the baby movements, recently? And then overall history, yes, those 3 questions we must always ask. I'm glad you did ask about the mental health screening. So just make sure we ask that as well, because if she's anxious and she has a bad experience, now she's feeling there's a pressure, they want me to go for a vaginal birth, I do not want to, she is likely to feel, struggling with her mood, likely. So that was good to ask. Check about the sport, the partner, and any other sport she has. Is she happy and safe with the partner? VT disc assessment you did. The most important thing, we need to ask a bit more detail about the first cesarean section as well. So when you had the cesarean section, was there any problems during the operation you were told by the doctors at all? Any problems in your recovery afterwards, like any infections or any problems in that time? And then she told me it was nice, smooth, straightforward. I went home doing this time. Now we can invite her to tell us about the previous delivery, if she hasn't already explained that in detail. But if she has, then you can say, so I can see, yes. And then you say, okay, so what happens basically is with the cesarean section, obviously, there are some benefits. It's a planned delivery. You know exactly when you're going to do, you can make your arrangements accordingly. And because you have the anesthesia, there is no labor pains. However, obviously, after, in the recovery, there is a pain of the wound. There are some effects of the anesthesia. It increases the hospital duration, and it reduces the mobility. It increases the risk of getting blood clots in legs and lungs, which can be sometimes quite life-threatening. And you require pain relief for a few days. So that pain is there after the operation. And then, so what happens with the cesarean section? So we have told a bit of advantage, and then when you say, and then she might just say, yeah, thank you, I had that first time, it wasn't really bad, it was straightforward. And then even she doesn't say it, then you can say, usually in the first cesarean section, usually that goes very straightforward. However, after any operation and any cesarean, the tissues, they heal with some scarring, we call them adhesions, and your bladder and bowel are just next to your wound. So this time now, when we go for the repeat cesarean section, there can be a risk that the possibility that your bladder and bowel are, your water pipe might be, stuck with the your previous scar on your uterus or even the uterus, and obviously that's going to increase the risk of injury to your bladder, bowel, and blood vessels this time as compared to your first cesarean. So we need to compare, basically, kind of. And the other risk which can be when you have you have repeated cesarean sections, then obviously the risk of these adhesions in the next pregnancy is going to be quite high. You will be more likely to have a cesarean section next time as well, after 2 cesarean sections. And then the other risk is that your water birth can be low-lying, because the water birth can actually attach to the previous scar where we open the womb. And if it does there, we got it placenta previa, and it gets stuck deeper into the scar, or even sometimes it can get attached deeper into the muscle of the womb. And because it's in the front as well, where next time we will have to open and deliver the baby, it can cause life-threatening baby for the mother and the baby, and for the baby as well. And this is one of the very important reasons why we encourage women to go for a vaginal birth if they can. All right, so if they can. So that's one of the very important reasons. And then obviously, if there is any complication happens because of the previous scarring or anything, you know, there is a risk of bleeding during operation as well. And if an injury happens to bladder and bowel, that will require repair. That this can have its own complications later on. Then that will increase the hospital stay, risk of blood clots in legs, lungs, and that itself is a life-threatening condition. On the other hand, with the vaginal birth, yes, so start from acknowledging her trouble. I understand, yes, you are right. It's obviously it's a bit uncertainty with the vaginal birth, then the contractions and the pain. Although we do have very good, you know, the pain relief available these days, like to have a gas and air, pethidine, and then later on epidural. But with the epidural, yes, that is something which can happen. Obviously, you know, if the anesthetist is busy doing with some emergency, then yes, there can be, you know, there is a possibility sometimes there can be a delay to give the epidural. However, if you would like to consider the vaginal birth this time, what we can do in the plan, we can write down to, you know, to arrange epidural earlier on in the labor. So, you know, as soon as you enter into the active labor, they will try to get your epidural in place. However, obviously, again, I hope you understand this is not something which we can promise and make sure that happen. I wouldn't worry about saying I will put those marks or priority or anything, because there is nothing like that which exists. We can't put the priority just because somebody, if there is an emergency, there is an emergency. The anesthetists have to attend that. And anesthetists won't delay it unnecessarily. If anesthetist can't see this woman, he will come and see this woman. So we don't need to talk about putting priority. All we can say, yes, we can put the plan in place to have epidural earlier in your labor as soon as you enter into active labor. So that's what we can, you know, try to arrange for you. Obviously, you know, the benefit, because you had a one vaginal birth now, your chances of having a, you know, smooth delivery this time are much higher than the before. However, if you, I mean, you could consider, if say if you are in labor and you, you know, didn't like, or your pain relief is not arranged, you think, or any reason you still feel you would like to go for a cesarean section, we can do your cesarean section even during labor as well. Although, yes, there is a slight increased risk of complications when we do a cesarean in an emergency rather than in a planned cesarean. And then the other thing which I can see, you know, regarding your placenta, that it was retained last time. So there may be a small risk that the placenta may get stuck this time as well. And that risk is same both in vaginal birth and in cesarean section as well. So that risk of to remove the placenta and the bleeding is almost same in both ways. And after that, then we need to ask her. So after all this information, how you feel? What would you like us to do? It's her choice now after this, what you want us to do. Yeah. So if she says, okay, I will think about, you know, and I want to speak to my partner, and then I will let you know. You can say that's absolutely, you know, fantastic. So I'm going to give you the written information for both, actually, for the vaginal birth and also to have a repeat cesarean section. Have a read about that as well and discuss with your partner, and then obviously let us know, and then we will arrange it accordingly. Because she's uncertain at this stage, so we can tell her, if you chose to go for a cesarean section, then we will arrange that cesarean section being done when you're 39 weeks pregnant for your gestation. So you keep an eye on your baby movements, and, you know, when you're ready, let us know. If she chooses to go and is clearly say, no, thank you very much, all that sounds okay, but still want to go ahead with the cesarean section, you can say that's absolutely fine, as long as you are, you know, you understand the disadvantages of both sides. And if your decision is to go ahead with the cesarean, we will arrange that for you. It will be done at 39 weeks. So I'm just going to go now and, you know, speak to my consultant and inform about your, so that we can book you in our list. All right. And then, yes, give the information and let her go. Any questions?
Dr. Safiya?
Yeah.
If patient decide to go for cesarean section again, then we will not say, okay, we will arrange our meeting with consultant again,
No.
not for the decision person.
No, she's 36 weeks already. And when we're going to the clinic and the list are very busy, so we can't just make one. And if you want, if you feel you want to, and that's why, I mean, you need to go straight in that stage and speak to the consultant anyway, because If you're booking somebody for cesarean or any, if it's a vaginal birth, she happy with go ahead with that. That is fine. You don't need to do it. But if she wants to go for cesarean section, you just need to go to speak to consultant anyway that this woman wants to, so that we can add into the list. And if the consultant will feel different, she can always come down, or he can come down and speak. Because you're doing the clinic and the consultant is somewhere in the clinic as well. They can come down and there and talk if it's required. So for you, it's all you need to say is that no, I'm going to go and speak to my consultant and inform you the scenes, so we can put you into our, book into our list.
Thank you, Dr. Safi. Thank you.
Should we also include the postnatal advice here?
One by one, please. So should we do what?
Regarding the consent, we will discuss consent now, or we will arrange another appointment. Like
Okay,
she's agree for.
yeah. Okay, thank you. That was a good point. That's a good point. So basically, when we were doing the talk counseling and telling her about the advantages, that was the consent, right? So
Why is it not?
at the end, when you say, I will go and I will go and speak to my consultant, so we can put you to the list. Then you can say, and I'm then just going to bring the consent form as well, so we can, get the consent and get it signed as well. That's all you need to say, because all those things which you were talking about, increased risk of, bleeding, injury, next time placenta previa, creta, per creta, whatever, that is all what we were supposed to discuss in the consent. Okay.
Dr. Sophia, can I ask a question?
Yes.
So if she decided for a cesarean section, is there any point to discuss with her the bilateral tubal sterilization?
Ooh, why?
As an option for a permanent contraception?
No, the sterilization is no more, what I should say, preferred. Sterilization is no more preferred option of contraception anyway. She is 37, but still we do not offer routine sterilization with the cesarean anyway. Even if somebody wants to go for sterilization, in spite of all the discussion which will take place with them regarding lot methods and everything, we try not to do along with the cesarean section, because at this stage, when they are towards the end of the pregnancy, it's likely that they feel overwhelmed because of the problems of the pregnancy being being hectic and all that stuff. They're more likely to take a decision which is not really well thought through decision. So no, there is no role at all whatsoever to discuss the sterilization.
All right, thank you very much.
Excuse me, Dr. Sheet. So if this same scenario is for a previous 4 or previous 5 cesarean section lady, I mean, definitely not for a previous 1 section, but after 4th or 5th section, can we offer, like, I mean, just mention it that ideally she should not be getting pregnant again, so she should use reliable contraception, and there are LARC methods. However, sterilization is also an option. Can we discuss in that scenario?
So in these women, I mean, it's not really usually the theme of the exam they will put like that way, but yes, if there are 4 or 5 cesareans already and all the children are live and healthy, then yes, you can speak about by saying that you have an every time this repeated cesarean are putting your very high risk of getting all these complications. So it will be really good idea to consider your contraception straight away after your cesarean section. So how you feel about, we're going to offer a LARC method to put the coil, whether it's a copper coil or the Mirena coil, just after the cesarean, at the time of cesarean.
Okay, thank you very much.
You're welcome.
Madam, is there any cutoff that maximum cesarean in UK done, like 4 or 5, or say for example 4 cesarean, patient is asking maximum how many cesareans I can have? What should be the answer?
That's interesting question. There isn't any cutoff.
Ma'am, in UAE it is a commonly asked questions, especially our Asian origin. They ask us. So sometimes we don't have any guideline related that.
Okay. So Right. There is no cutoff. That's the first answer. The second is, all we need to tell again is that every time you have this operation, it is scarring, blah, blah, blah. It increases your risk of getting that placenta and the lobe gets stuck in there and bleed. And obviously, after 2 or 3 C-sections, this, risks start going extremely high. So, that is something we can review every time. So we don't give them any certain number. We tell them, yes, after every cesarean, it is very high. And then just like as Selena asked the question, like if it's like 4 or 5 cesareans already, then yes, we will be talking to them about, and we will make sure we actually sort out there some long-term contraceptive method. And if she doesn't, want to have that one, then we can discuss the options with you. Then sterilization is one of the options as well. We will discuss with that particular woman. We can't if she doesn't want to. First hand, I will offer her to have a coil. And if she's happy with that, we'll just put that after the cesarean section. And if she's not, then yes, we can just tell her and say, these are the options you need to consider. And then if she says I want to have I would rather go for sterilization, then we can do that. But I don't see any reason why a woman who can have the coil immediately at the part of the stadium, you will say put me sterilization. But yes, there can be. There's no definite number. But yes, after 3 cesareans, the risk actually goes sky high.
Sorry, can I ask everyone, after asking the question, can you please turn off your mics and ask Dr. Jabin to speak only? Because although she explained it very well, but we were not able to listen to most of it because of the mic making the noise. So I'll be grateful. Thank you.
Thank you, Sadia.
Yes, Dr. Safia, we didn't hear what you answer.
Okay. In response to repeat cesarean sections. Okay. So for the repeat cesarean sections, there is no number we can give as a cutoff. But obviously, yes, what we can do, again, if that question is asked, you will start by saying, okay, so after every operation or after every cesarean section, the tissues heal by the scarring and adhesions, and your bladder bowel and blood vessels, they can all get stuck with each other. And the next cesarean, we need to separate them first to deliver the baby. So there is a very high risk there can be injury. And obviously, this risk keep increasing rapidly after every cesarean section. So, if somebody has 3 or 4 cesareans already, or 3 cesarean, then I will be discussing basically as a part of my to say, I mean, we do these days discuss with everybody now when they are booking for cesarean and even for normal birth, offer them to put the coil straight away. So that will be done anyway. But yes, I will stress and insist that somebody after 3 cesarean, 4 cesarean sections, yes, I will say the risk of all these complications, and as a result of them, the bleeding and the risk of death, I will even mention that as well. They can be even, it can be life-threatening, they can even be a death. So, yeah.
Yeah, Dr. Safia, this is a very important question. So when we are taking consent for any patient, and the death is mentioned in every consent, so we have to tell them the risk of the death as well, like a hysterectomy or cesarean section, or even I think in the hysteroscopic consent it is written. So how we can explain the risk of the death?
Sorry, what we need to mention? Date?
Yeah, in every consent, like placenta previa or any cesarean or hysterectomy consent advice, the risk of the death is also explained. It is 1 in 23,000 or like this. So how we can explain this thing to the patient?
Give the number this much, okay, and reassure straight away as well. This risk is extremely low, but because although it's 1 in 100,000, this risk itself is very serious and significant, we like to inform the patients. Okay, who is next?
Next is Neelam. Is she here? Neelam? I didn't
Yes,
see
yes,
her.
sir.
Yeah. Okay.
And is this fifth patient, Ramila? Okay.
Yes, this is the fifth one.
Okay, thank you. Okay, that's the next one. Are there any breaks? Yes, Rania, after this patient, we are going to take a break. Right, okay, so this is for you, and there is another page as well. So when you have done your first page, please let me know so I can move it to the next page, okay?
Yes, doctor. Next page, please. Um, uh,
Yes, okay, this
any
is
uh,
2 minutes.
any staff available now?
Right, okay, so yes, okay, you
Midwife.
have your, yeah, so your consultant and anesthetist consultant are on call. You have an obstetric registrar, anesthetist with you. You have your SP3, and you have a coordinator midwife, and then you have 7 other staff midwives.
Okay. Okay. So, hello, I'm Dr. Neelam. I have seen I'm here for labor ward prioritization. I have seen received all the over from all the rooms, and I'll go room by room, and accordingly I'll send the staff accordingly to the rooms. So in the room number first, the patient is 39 years with leaking 24 hours ago, and she is previous cesarean for placenta previa, but her CTG is reactive, and she has no other high risk factor, only clear liquor is draining, and she's waiting for willing for vaginal birth and doesn't want any medical intervention. So in this room, I'll send my midwife to again see all the vitals, and because there is no hurry, she is for vaginal birth. The CTG is reactive, and sorry.
It's
Yeah.
all right.
Yeah. CTG is reactive, so I'll send her to see whether the contractions are increased has or not. When was the last pelvic examination was done? What is her dilatation right now? And whether there is any scar tenderness or not. Then I'll go to the room number 2, where there is a twin pregnancy. She's 35 weeks, age is 36 years, and she's in spontaneous repair with first vertex, and the head is engaged. And CTG is also reactive, but the second twin is transverse. So she's coming up to the second stage. So I'll ask my midwife to again assess her whether when was her last pelvic examination done? Is she in full dilatation or not? And take her vitals also, see her uterine contractions are been regularly there. And if she is about to deliver her first baby, then I'll ask my ST3 to go there and take the delivery and call me whenever the second twin is about to deliver, because the second twin is transverse, so may need to do either external cephalic version or internal portalic version in this case. The third room I'll go, where it is in quite an emergency. The patient had delivered a male child 4.6 kg 4 hours back. She had PPH already 1500 ml she had lost. She had secondary episiotomy repair, and she is on epidural. Presently, her BP is 100 and infusion of oxytocin is running. Urine is 100 ml since delivery, that is quite low. So and she has some trickling of blood also. So that means she is still bleeding. So she needs all PPH protocol to be followed. I'll call for help. I'll call my anesthetist resident also and midwives also to put her 2 white bore cannulas, all the protocols for see her vitals, put her catheterization to be done, and labor. My consultant has to be informed. Consultant anesthetist has to be informed, because she may require a review and in operation theater. That is, we'll have to inform the theater team also. And at the same time, we'll have to take the blood samples for coagulation profile, FBC and LFT, RFT, as well as to send for group and save. And we may need to see whether she is having atonic contraction. I'll examine her whether the uterus is relaxed or contracted, and whether it is traumatic. So if it is relaxed, we'll give oxytocin there and then only, and we'll ask the midwife to make all arrangements to shift her early into the theater to assess her under anesthesia. The fourth room is for cleaning. Now coming to the fifth room, ma'am, can you change the slide?
Yeah.
Coming to the fifth room, there a patient who had cervical cerclage done. She's 31 years. She has occasional contractions, but she's very anxious, and there's some discharge, and this uterus is not tender. However, the CTG is reactive. So this patient requires we'll reassess her. I'll reassess her whether the contractions has increased in size, whether her dilatation has increased, whether she is in proper labor or it's only early stages, and accordingly we'll give her uterine relaxants, and whether there is PV discharge is, I'll see by speculum examination whether there is leakage or amniotic fluid leakage, and a proper antibiotic has been given or not. I'll check it, and I'll ask my midwife to follow her. Now in the room, if the contractions, and inform me if the contractions are increasing in intensity and frequency, and the dilatation is increasing, then we may need to remove the cervical cerclage. And at the same time, if she is not contracting contracting, and if the uterus has relaxed, then also we need to give her betnisol to in case she goes in preterm labor. So we'll have to give her a dose of steroid also. In room number 6, there is Mrs. Belinda Kent. She is 38 years, 38 weeks, 26 years, para 1, and she is 2 centimeter dilated, but there is SRM, clear like a draining. Contractions are less 2 in 10 minutes, but it is undiagnosed extended breech presentation. So here the counseling is needed to the patient because the breech presentation was undiagnosed until now. So I'll ask my ST3 to counsel the patient whether she is into vaginal breech birth or she may like to go for a cesarean section. Because liquor is draining, so there is no role of external cephalic version right now. So after the counseling, if the patient wants to go for cesarean section, then we'll have to inform the OT and make her arrangements for her cesarean section. But if she is not willing for, after all the counseling about the vaginal birth, breech birth and all, if she is willing for vaginal breech birth, then we'll inform the consultant and allow her for continuous CTG and one-to-one care. Then the 7th room is the information is not much about the patient who is coming in ambulance. She's 32 weeks, 28 years old, pregnant, and complaining of severe headache and vaginal bleeding. So she might be pre-eclamptic, or there may be some cerebrovascular accident or CVA. So I'll inform the HDU to make a bed available for her for the patient, and do all arrangements, and also try to check her further information about her, what may be the reason, and keep a midwife over there to receive her, and check whether IV lines are there, or what are the vitals, what conditions, what investigations to be sent immediately, and what investigations have already been done to her to know the diagnosis, and how much she is bleeding, whether she requires blood, and what is her BP, if she is into impending eclampsia. So all these arrangements already we have to do, and if she needs a preterm delivery, then we'll have to inform the neonate unit also that the preterm baby may come. So I'll check for whether the cot is available there or not, and if available, I'll ask that I'll tell them that it might be required for a 32-weeker. Then the room number 8 is 39 weeks old, 39 weeks, 42-year-old lady with slightly higher BP, 145/95, with meconium staining, and she is not contracting. The CTG is, however, reactive, and urine albumin is awaited, and other blood tests also I need to see whether what is her renal function test, liver function, whether SGOT-PT, this AST are increased, or whether the platelet count is low or high, whether she has any symptoms of preeclampsia, and accordingly I'll manage her with if she is into impending eclampsia, may need to give her Mexel and need to deliver her fast if the urine albumin is also high, and also give her antihypertensive. And if if all parameters are normal, and if she's willing for normal delivery, then we need to augment her labor because she's right now not contracting. So I'll ask my consultant to whether we can start with oxytocin for her to augment her labor, because she is a case of PIH. So we'll decide accordingly of the investigations and albumin result and the signs and symptoms of preeclampsia, whether she needs augmentation or she needs cesarean section right now. The last room is empty. ready for induction. The patient is about to come for induction of labor. So that patient, I'll ask my midwife to take her history and accordingly take her vitals and all examinations, and accordingly we'll start with the induction of labor.
Okay. And your priority, your staff?
Yeah, my priority would be room number 4, where the PPH is ongoing. So this would be my first priority. I'll attend that along with my anesthetic staff and the midwife. So all of them one can put 2 cannulas, one can put oxygen, one can put catheter, one can take blood samples and blood for grouping and cross-stitching. Another one can inform the OT, and my consultant will also be informed. So that is the first priority. The other one is this room number 8, where she might be a case of preeclampsia.
Your time is over. Your time
yeah.
is over.
Yes, ma'am.
Right, okay. So with the labor ward prioritization, thank you, Neelam, thank you. You did good. And you managed to talk about all the stations within the time. I will be worried actually if I have finished all the room within the time and I'm left with the time. I mean, I must have missed something somewhere. Right, okay, so the labor ward prioritization, what is the purpose? Why they put that in the exam? Okay, this is basically the handover, okay? And the handover, obviously, you know, usually what happened is there had been the cases where some maternal deaths happened or the complications happened just because when the patients were handed over, when the teams were changing, the information about patients and sometimes very important information about some patients was not, you know, handed over to the next team appropriately. And for some reason, that team got busy as soon as they started there. And because of that, those patients were ignored. That patient was ignored, and then it was too late. So as a result, it ended up either in some major complication or even into maternal death. So for that reason, you know, as it happens, obviously the analysis happen and everything, and then they try to devise some tool where it can be ensured that, you know, there is a proper, comprehensive, appropriate handover done. Okay, so there is a mnemonic that SBAR basically is that came for the handovers. So, and the handover is like, I mean, it can be, usually there will be time given. It will say either 9 a.m. or 8 a.m. or 9 p.m. or 8 p.m. So you need to imagine that picture that, you know, we see the people who work here in this country, they are aware, but for others, you need to imagine the picture that your night team is there. So your night team registrar, ST5, your ST2 or ST1, and your coordinator midwife, or maybe the midwives just do their own handover separately. So you are with that team, night team, and you are taking over. So and there is the, you know, the big board, you know, whiteboard where they have given, I mean, in this scenario, they've given a lot of information. You actually don't have that much of information on that board. That briefly tells, you know, it might say 39 week and SHROM, and maybe, you know, if there is some complication that might be written. Or if they are in active labor, there is usually written maybe 4 centimeter dilated or waiting episiotomy suturing and these type of things. There's a lot of information basically is not there. Okay, so so the night team at the registrar start giving you the you know, the over. They are telling you, no, they are tired for the night and the however the day. So the concept behind this labor ward prioritization is that you have your active nurse alive at that stage and fresh enough that if some information is not given to you, you need to be aware what important piece of information I need to have about that patient, so we can decide from where we're starting, which patient we are gonna go first, so we don't actually, you know, delay any urgent patient requires to be seen. Okay, so that's why you will follow SBAR. So the situation will be whatever is given in that scenario, then you need to have asked the background information. So you need to ask that information. Are there any other maternal or fetal complications in this pregnancy? And if the patient is in labor, when was she last time examined? What is the cervical dilatation? CTG, can I have the CTG? Can I have the partogram? You need to ask that from the examiner and get it, because unless you have that current information in front of you, most of the examiners will not volunteer that information to you, because that will be taken as that you actually are not aware that how important that information is. So you need to ask that information and then give the specific plan for that patient, and also, you know, label your priority, how you will do. This is not about giving the full management. As I said, it's a handover. It's not about, you know, we don't want you to give like full how the PPH will be managed. Now, all you need to is a basic thing. Yeah. So I will initiate the protocol of PPH. So say, for example, for the room 3, you know, I can see in room 3, you know, there is a major PPH. This woman already has 1500 blood loss, and her blood pressure is this, oxygen starts low, and her urine output is very poor, 100 mils only, and her you know, the hemoglobin has came down or whatever, and she's restricting. So she is the first emergency for us to go and see. And then you need to say, all you need to say for this particular patient is, I will initiate the protocol of major PPH, and I will call, you know, for the help, and I will ask to call my consultant anesthetist, alert the blood bank, and also to the hematology, because we will needing to. So when you say I will start the protocol of PPH, that means that you are going to basically, you know, follow all whatever is given. And after that, if you don't know, all you see, I will approach the patient, see if she's conscious. Then we will start with the, you know, the protocol for the management. If she is unconscious, then we will start from ABC, and, you know, the CPR first. And then depending upon the cause, whether HNE or any tear is the cause, we will proceed further. That's all, that's enough. All before that, you need to ask a bit of background information though. Yeah, any other respect to this woman has, is she preeclamptic or any, you know, the placenta side, what it was, and what was the reason initial of PPH. So that's one thing. Don't go into further details, because then you will not be able to finish. And it's not again about, you know, arduous, and this, even this much of piece of information when you say we need to do, is because that is like you need to verbally say immediately, because that's what is required to be done. So regarding the priority and which way we are going to go, room to room or whatever, I will suggest, and I usually suggest that you identify your 2 or 3 or 1 or 2. Obviously, there will be always a major emergency, and then couple of urgent cases. Identify them beforehand, you know, when you're reading, and start from those rooms. And then after that, you can say that for the purpose of examination, I'm just, for the rest of the rooms, no, I'm going to go room wise, allocate my staff, and also I will tell the order of my priority. Yeah, but that will be better, rather than just starting from room 1 or trying to do the whole, you know, if you do room 1, room 2, it loses, although you have said it, but it loses that impression that you have reacted to emergency that way. Yeah, because what happens if there is an emergency happening, I may not stand there actually to take the whole handover. Yeah. So, or the previous team will not leave that PPH till we have actually taken the handover and gone, or I might need to send some people to replace them while I take the handover. Yeah. So maybe the consultant is there as well, and the consultant says, okay, you take the handover and I go, or you might need to send your ST3 or other people to release some of the stuff from there. So talk about the emergency first, urgent room first, and then go for the rest of the rooms. All right. But go according to this one. So say, for example, on this one, we talk about this, that will be the first one room for you to attend. Then we see on the next page, when we have seen this, it looks like these 2 rooms can be a potential, you know, the high risk and urgent cases as well, just because we have incomplete information here. That's why. Yeah. So this one, someone coming by the ambulance, means that there is, you know, some serious, either the bleeding is quite a lot, or some other risk factor. That's why ambulance has been called. So I will just say that I'm aware in room 7. Room 7 will be my second priority to take action. So this is a 28 years woman. So the situation is 28 years woman at 32 weeks, and she has been on the way with a severe headache and some vaginal bleeding. All right. And then again, you need to say, I need to have more background information here for this woman. That, okay, so how much blood loss she has, have we reviewed the notes? I will ask one of my, you know, have the team who already is working, they have reviewed the notes, what are the risk factor? Is she already known case of a high blood pressure or preeclampsia? is she known case of low-lying placenta? So we need to review. So if they haven't done that, you ask them. If they haven't done that, then you immediately going to ask your SD3 basically to access those notes, get all that information, get one of the high dependency unit rooms ready for her, and allocate one of the senior midwives to be ready for that woman to receive. And as soon as she comes in, you're going to tell them that obviously immediately they need to put her on the monitor to check blood pressure, assess the blood loss, and check blood pressure and urine protein. And then immediately call you past 2 whiteboard cannulas as soon as she arrives, so that we can then start managing. So that's about her. Then room 8 is she has arrived only half an hour ago because it's 8 o'clock. 42 years para, 39 plus 2 week, blood pressure slightly high, 145 or 95, strong with meconium, not contracting, cephalic baby. This probably won't be there, this information. 3/5 palpable CTG, you need to ask this one. Is there any CTG available? Can I have a look on that one? And obviously in this one, everything, whether we are going to take that as an emergency or not, that depends absolutely on this urine result. Whether there is protein present. Does she have any other symptoms because of this high blood pressure, like headache, blooding of vein, and epigastric pain? So this is very important background information we need. And then any other complications, maternal complications or any fetal complications, any concerns about the growth and the well-being of the baby. So these two questions you all can memorize, basically these two statements to talk about the risk factors behind any maternal complication this pregnancy, any fetal complication, any concerns about the growth and the well-being of the baby. Okay, so just say that covers the whole of this antenatal information. So and then you will say yes to the CTG if they have shown the CTG is reactive, and then if urine is clear as well, there is no protein, and if there is protein, then obviously according you will either initiate the protocol for preeclampsia, and if there is no protein, then obviously we start the monitoring, continue with the CTG, and then once we have dealt with the emergencies and the urgent cases, then we will review and plan further whether we need to induce her. All right. And then now you can say that after these, no, I'm going to go room by room, or if you are, whatever you want to choose now how I would like to do that day, and start practicing from now, right? So room 6 and rooms on the back page, the twin delivery, and room 7 can be actually your next one because she's a breech. All I need to do for this breach is, now again, for the breach, it will depend what discussion has taken place. Now look, it says the breach, this breach arrived at 3:30. It's 8 o'clock. This woman is there for almost 3.5 hours, 2.5 hours, whatever, 4 hours already. So we need to ask that team, has, because it says undiagnosed breach, so have this woman been consulted and informed and discussed about the mode of delivery? What she wants, whether she wants to go for a cesarean section or she has opted for vaginal birth, right? When was this last examination done? That's another background information. Is there any other maternal or fetal complications in this pregnancy? Yeah. And, do we have any idea, has the scan been done to see is a favorable breach for vaginal birth if she wants to, and what is the estimated weight of the baby? Okay, so that all depend. And then ask the examiner, do I have that information? Look at the CTG, look at the partogram. And if no, there can be two possible situations. The one answer may come from the she has opted for the vaginal birth. If she's for the vaginal birth and the rest information is given, she's suitable for vaginal birth, then you will say, okay, so I will send one of our senior midwives into this room. And this breach obviously needs to be delivered by the consultant, because vaginal breach should be delivered by the senior clinician with the experience in breach delivery. So that will be consultant. So we'll inform, ask the midwife. Then when she approaches to the second stage, then she needs to inform us so we can attend the birth. So that's about the breach. And you will see how much it changes according to what they said. If she says, if the information given back to you is, no, she has opted for vagina, she has opted for cesarean section. Okay. So, but the team has been so busy, the night team still so far, that they have not been able to take her to theatre, right? Okay. So what is the current information on the partogram? What number of contractions, how much dilated she is? So if she wants to go for a cesarean section, then it needs to be, it is category 2 cesarean section, yeah? Or category 3, no, not category 2, category 3. All right, so we need to, but it needs to be taken. She's already, if she's contracting for 3.5 hours, we kind of need to deliver her in the next 60 to 75 minutes. So you will need then ask your SD3 to, when she come out of this room, she needs to take a consent, or have they taken the consent already? They might have already done the consent. Then in case, if she's already found in her labor, we might need to, there are two emergencies in case where ST5 and consultant of the morning team gets stuck, then we can request the night consultant to stay behind, deal with one of these, okay? No patient will wait. We will not make any patient to wait if they need to have an urgent action just because, number one, theater is not available or the personnel is not available. If that team is fully occupied, ST5 and consultant, then you need to ask the night team consultant. And if that is not there, if it's a morning time, then the rest of the whole team is around. You can ask from any other consultant or any other ST5 can be called upon. So we won't be delaying only for that reason. If there is a theater busy for some reason, one elective is happening there or whatever is happening there, usually most of the labor wards, they do have two theaters. So we will ask to open the second theater. If for any reason there is only one theater, we will be communicating with the general theaters to take this woman over there. Okay, so we will not, unless obviously there's no choice left, we won't be actually just waiting for that, that there's no person available. So that's all about the labor ward. That you need to be aware of these pathways, these procedures. Yeah, and now then afterwards you can take it from room by room maybe, or otherwise continue the way, because we have done it 1,000 times before, so I know what the patients are. So I can go into room 2 now, twin DCDA, spontaneous labor, first stage of labor, twin vertex, second one transverse, CTG is reactive, coming up to the second stage. When was the last examination done? This one. Is she fully dilated already? So always ask about the findings which are given when the last examination was done. Can I have a CTG trace? And again, the same question, background information, any other than DCDA, any other maternal or fetal complications, any concerns about the growth of the babies, the fetal well-being during antenatal period or till so far. So then you're going to send another midwife in this room who will continue with the monitoring, and then you will say, because the first baby is cephalic, that can be delivered by the midwife. However, they need to, when the delivery is imminent, they need to call the ST5 or the consultant. One of them needs to be there. Because the second twin, if it didn't, went into cephalic position itself, then that will require either an internal pedagogic or external ECV. So, you will need to be, and obviously the patient needs to be counseled. You will make sure the patient has been counseled and informed about the intervention will be made required to for the second baby. Room 1 is induction of labor, SHROM, previous section for placenta, previa, long lie, cephalic. Uterus tightening, temperature is given, the CTG is reactive, like a draining, very keen on vaginal birth, does not want any medical intervention. So again, induction of labors. Inductions, if we are busy, some emergencies are going on, or some urgent cases are going on, we will defer the inductions unless they're higher risk, and for some reason we cannot, right? So for that reason, the background information is always important, must ask them. So SHROM, okay, the temperature and stuff is given. I don't think it will be given in the real exam. So you need to make sure, is this patient apyrexia, the CTG is reactive, any other complications, any other maternal or fetal complications. And, has she been, she's term already, she's not preterm, is she? Yeah, 39. Yeah, so if we can safely exclude, there's no other complication, she's apyrexia, nothing, we don't need to basically do anything here. Just continue with the CTG. Ask the midwife to inform this woman, and we will just observe to say if she, progress into labor herself, then it's fine. Otherwise, after managing the rest of the emergencies and urgent patients, we will review, and then we can think about augmenting the labor accordingly. Next room, this cervical circuli, that was fine again. She's here since 2 a.m. So 6 hours she's already here. So you need to check, has she been counseled about the possibility of, threatened preterm labor? And what has been the, all those findings we need to ask. So what about the contractions? Have they increased, or what was the spectrum examination? Has she ruptured the membranes? Is she imminent into, just those routine things? Is she imminent labor? Has she been given, I won't just say I will ask one of my to go and give the steroids. I will assume the steroids have been given already. She arrived at 2 a.m. So we need to check, has she been discussed and given, has somebody had the time to speak to this woman and counsel about preterm labor? and the cot is do we have a cot available on the neonatal unit? So these are the safety points, few of the safety points you need to establish. Then ask for the information. If she is a calm patient now, some tocolysis has started or she has been given steroids already, then it's fine. If she's not in imminent labor, obviously we don't need to start magnesium sulfate. Otherwise, if they give you that type of information, then you need to check whether she has been, and then obviously whether the cervical cerclage has been removed. And if not, somebody needs to then immediately remove. Okay. So that will all depend. Who will see that? Somebody asked me. That will depend what information we get. If she is a calm patient now, she's not contracting, and that's what we will guess. If she still have the cervical cerclage in place, suture in place, then we can just send one of the midwives there for the monitoring. And yeah, so we are done with all of them. But otherwise, for you, obviously there can be unfamiliar stations. Deal with your emergency just the way I have told, up to that level. Always speak the protocol. When there are emergencies, we absolutely follow the algorithm of the protocol given by the NICE guideline about the unit. Okay, so when you say that, and just the immediate things, do not go into the detail. Then I will examine the, you all need to say is then we will assess whether the reason for PPH, cause of PPH is atony or the tear. And according to that, then we will proceed for the further management of PPH. I need to obviously call the consultant. Do not go into detail. I will examine, remove the clots. I will do this and syntocinon. If that's not again, I'm going to do. I mean, if the time allows at the end, then yes, by all means, go into that. You can speak then. But what happens sometimes when you go into detail, then you're not able to finish the rest of the rooms. And this is very common happening. Most of the candidates not able to complete all the rooms. So withhold that one, and at that end, if you have a time, then yes, talk in a little bit more detail about your emergency, how you're going to manage that emergency.
Ma'am, this time in the exam, all my colleagues, they have mentioned that there was only one line about the labor room priority, and when they were asking like any other info, then they will say blood pressure 180 by 110. So it looks at outset like a routine patient, but after checking with the info, it will be like an urgent patient. So with the Osler system, how to tackle these issues? And we can't see the full 8 patients list at a time. We can see only 3 or 4 patients. So we have to tell the examiner that where is the other list or something like that.
Okay. So that's what we already said. Is that Dipti, this is what we said. Like on the labor, basically on the labor board, this much of information is not given. Just the few 2-3 points. So it is unlikely that there was only 3 stations given in one, because when you're given initial 2 minutes, you need to scroll down your cursor to see the next pages. So maybe the girls who told you or spoken to you, they may not have scrolled the page, and they just saw the first page, and then obviously in that time they came about. And then yes, you have to, you need to ask the information, but this main information will be there. If there is some major PPH, that will be given over there, because that's what the purpose of that board is, also during the day as well. Say I have done like, say I'm registered, I'm gone in theater, I did one reading for whatever XYZ, fetal distress and whatever. As I came out, basically, I then had to rush in another room and do the fetal blood sampling. And then I have to rush in the third room. There is some abruption or whatever. And then I ended up taking that into theater as well. So all together, I have now the chance after 4 hours, basically, to have a breath and then try to find out what's going on in the labor ward. So that's the first thing the registrar consultant, everybody will do. They will come on the that board and they will have a look, because it get updated. The important point will be written over there, PPH or this or this. So that's what gives you an idea about what's happening in all the rooms, and then you take the action accordingly. So yes, there will be only a single line or 1.5 line, and then that's why you need to ask the background information. So that's your capability. When they give the background information, it's just normal, natural. You all do that all the time. Don't feel stressed and obsessed. Just feel yourself just being on your floor, and whatever the information is given, give your plan accordingly, and just go to next room. We will be knowing a couple of more labor wards. I have one from the this exam as well. So I will be putting for next session in delivery management. So we'll be doing 2-3 at least labor wards so that you are actually getting to have this, what to do with them.
Dr. Safiya, just I have one question, if you don't mind. Just for as a summary, the order you mentioned for prioritization. So would you mind just to repeat it again? The
For this
order of
particular, board, yeah. So the first one
yes,
is your PPH. This one is your emergency room, the first one.
yeah,
After that, my immediate attention is required to assess these 2 rooms, to get information about these 2 rooms, to assess the level of urgency. So
yeah,
when you listen, you can see like when you get the background information. So depending on that background information, these 2 rooms will be decided whether we need to then jump straight over here.
yeah.
And then after that, I need to know about the breech, because in case if she has opted for vaginal birth and she's been contracting for last 3 hours or 3.5 hours already, then obviously we need to take her to theater as well. Okay.
Great.
And after that, I'll say I will go room by room and tell my priority and allocation of staff.
Yeah, that's fine. Thank you.
Okay, so Rania asked, do we have gynae prioritization? Yes, Rania, we will be doing in next session in delivery modules. We'll be doing some gynae as well. So we're gonna take a break for half an hour. So you all can eat and drink, jump a bit up and down as well to just do a little bit of stretching and then come back. So it is 10 to 12. We will be back at 20 past 12 UK time.
This conference will now be recorded.
Okay, can you all hear me?
Yes, ma'am.
Yeah, we got a bit of a temperamental internet today. Right, who is next, Pramila?
Anniversary.
Okay, Nilashree, this is for you. Okay, that's your first witness.
Hello.
Hello, doctor.
Hello, ma'am. Can you hear me, ma'am?
I can hear you.
I am Dr. Anila, one of the doctors in the emergency today. Can I confirm your name and age, please?
Yes, doctor. My name is Demeter. I'm 32 years old.
Ma'am, disturbance, ma'am. Hello.
Yes, hello, Anila. Keep going. We can hear you.
How can I address you?
You can call me Demi.
Hi, Demi. I've understood that you have delivered 4 days back and you have come with a severe headache. Is it so?
That's right, doctor. I had a baby 4 days ago, and first couple of days I was fine, but since yesterday, I'm really trouble with this headache. I took paracetamol, but that doesn't seem to quite work, and in the night I was really, bad with this headache. So that's why I'm here.
Do you need some medication for the headache?
I had some paracetamol just not long ago, about a couple of hours ago. So
Can I ask you a few questions or do you want me to wait?
no,
You
I'm all
need
right. I'm okay. I'm okay, doctor. I would like to get it sorted. So yes, please feel free to ask whatever you need to.
uh, okay, is this your first pregnancy, Demi?
Yes, this is my first baby. Yeah.
Okay. Did you have any? How was your pregnancy and your delivery? Did,
So it was all okay. I mean, I didn't have any problems during my pregnancy or during delivery either.
okay. Was it a normal delivery?
It was vaginal birth, normal delivery. Yeah.
When were you discharged after the delivery?
I went home like about 10 hours.
Okay. Do you have any disturbance in your vision?
No, I haven't felt any problem with my vision now.
Okay. How is your appetite and fluid intake?
It's been all right. I mean, as I said, I'm not getting much time to look after myself, to be honest, to eat and stuff. But I'm trying whenever I get a chance to eat. Yeah.
Okay. Do you have any support at home?
Yeah, my partner is quite supportive.
Okay. How is your urine output otherwise? Is it yellow in color or white?
I haven't particularly looked for the color, doctor. So I can't really comment on that.
Okay. Do you have any pain in the legs or in the chest?
No, no pain in leg and chest. No,
Any vomitings?
no, I haven't vomited. I mean, I'm feeling sick, but I guess that's because my headache is really bad at the moment. But I haven't been sick now.
Did you have similar episodes in the past?
No, I wouldn't say this bad. I mean, at times I could get some headaches, maybe when I'm stressed, but not that bad.
So you are not on any medication for this.
No,
Are you diabetic or anything?
no, I'm not.
No. You were not on any other medication, not following with GP for any
No,
medical
doctor.
condition.
No.
Okay. Uh, uh, Other than this, you are not having any fever or anything.
No, I haven't noticed any fever.
Okay. Uh, any idea about your height for weight ratio?
So my height weight ratio is 28.
Okay, that's fine. Are you able to breastfeed your baby?
Yes, I'm trying. I mean, I haven't got much milk, so I'm just giving bottle feed as well.
Okay. Demi, I've seen some of the tests were done for you. I think the urine test. because in that we see that they are what we call as ketones. That is when you don't have an adequate fluid intake, or you are dehydrated, or your sugars are high, it tends to be present in urine.
Okay.
Those chemicals are found to be positive in your urine. Otherwise, your BP is only slightly elevated, and as you didn't have any complaints during your, complications during your pregnancy, and this is your first reading, I would like you to get admitted so that we can monitor and find out the cause, what could be the reason for your headache, and also see how we can uh, improve your uh, diet and fluid intake.
Okay.
Is it okay, Demi, for you?
Yeah, that's absolutely okay, doctor.
Okay. What we do is, I would like to repeat your BP again, and we will see your blood sugars and some blood tests also to see how your hemoglobin and your sugars are. And then we would start you on some uh, with one cannula in the arm. We would run some fluids to check, and we will be repeating your urine ketones again.
Okay.
I would give you some medication for your headache also, and we would like to plan from some scan for you. And as you didn't have any other complaints, we'll wait and watch. Otherwise, we would, if the headache is not responding, um, we would get an uh, even the neurologist, that what we call as a doctor who is specialized in looking after this headache or anything
Okay.
related with the nerves. We would get his
Okay.
opinion, and I would inform this to my consultant, and also we would proceed accordingly.
Yeah, so what could be the
Okay.
possible reason for me having this bad headache, doctor?
Yeah, one thing is we can think of as immediately it is post delivery. We have to think of some either is there any clot in your blood because of the thickening of the blood which can occur after the delivery. We need to think of that, for which we will be needing to do an MRI to look into if it is not responding to the normal medication. As you do not have any other
What is this
issues.
MRI, doctor? What is
MRI
sorry? What is this?
is a specialized type of scan which will be looking into how the brain circulate. To look into your brain.
All right. Okay.
So
But do
depending
I
on
have
that,
to get admitted for that, doctor? Because obviously I
yeah,
got a
because
little baby.
yeah, you can get admitted in the mother baby unit where your baby can be with you, and you will have the support from the staff uh, regarding your baby to look after your baby. One of the attender can be there with you, and we as your ketones are positive, we will be repeating your ketones, because if the ketones are positive, there is a chance that you can go into unconsciousness or coma, what we say it is going to be dangerous for you.
I could go into coma.
uh, I am not saying it is you are going to go into coma, but if you are left untreated with this, which shows that these ketones are elevated, there
Hmm?
is a chance that it is dangerous for your this one. It can go to such an extent. So we want to find out what the cause would be, and treat accordingly.
All right. Okay.
As of now, we will keep a monitor of your blood pressure, and we will be giving you some fluids. You can take orally something to eat, and also we'll give you some medication for your pain control, and get opinion from the brain specialist. Is it okay?
Yeah, that's absolutely all right.
No.
Is that all done?
Yes, no.
Right, okay, so do excuse me, I have been eating at the same time. So this is your timer. Right, okay, so postnatal headache. Very
Ma'am,
favorite? Yeah?
first thing I was thinking of venous cortical thrombosis, something
Mm-hmm.
like that. Then, or a past history of migraine she doesn't have, or it can be a stress headache, what I was thinking, but the urine ketones were positive.
Mm-hmm.
So, I was thinking of any dehydration leading to these things, or
Mm-hmm.
diabetic, because sugars were not there in the urine. I was not much inclined towards diabetes, and also
Mm-hmm.
there was no past history. Protein was negative, so I didn't think of preeclampsia.
Okay. Yeah, okay.
Then she doesn't have vomitings also to go into dehydration, so severe dehydration. That's
All
what I
right.
could think of, madam.
Hmm.
Maybe
Basically, we
abdominal
do not
pain and
know.
all also I should. Ma'am?
We do not know at this stage
Yeah,
what can be the possible reason, right?
yeah,
So for that reason, we need to basically consider all the possible causes. You're right, our threshold to consider some VTE episode will be high. It's just because we should be keeping that in our differential diagnosis at the top line unless excluded. So that could be one. They can be very simple, starting from some simple reasons, physiological reasons, to go up to really serious pathological causes. So yes, it can just simply be because she's a first-time mom. She's not taking proper rest. She's not eating and drinking. She's dehydrated, and sometimes it's very natural to feel anxious with a baby as well. So that may just be as simple as that. She hasn't taken enough rest. She haven't eaten and drinking properly, so that's why she's having the headache. It could be, yes, our blood pressure seems to be just in the borderline, no protein, but she might just, head up to that in a minute. So we need to keep an eye on the blood pressure. So it could go towards preeclampsia. Yes, it can be VTE related, like the cortical vein thrombosis. It could be epidural related if she had an epidural. So we didn't ask about the
yeah,
epidural. Maybe some, yes, it could be with the epidural related. It could be something to do with the domestic violence. It could be
but
this woman is actually getting into postnatal depression, and that's why it is. So we need to really keep our options open. It could be one of the serious pathological reasons. She might have some, subarachnoid hemorrhage with that
yeah, yeah,
suite of reasons. So when we are doing the information gathering, we need to basically kind of think, keep these bullet point differential diagnosis in your mind and then work through them one by one. So after the introduction, first of all, just to establish her immediate well-being since birth to delivery. So yes, it's fine. The first question will be, how bad this is. Did you have any vomiting? When you started, is there anything which makes it better or worse? This question is always very helpful. You can sometimes get quite clear, clue from there. And then just keeping your the differential in mind, you can work through. So then ask about how she has been, how she feels her bonding with the child, with the baby. Has she been able to get enough sleep? Are you able to get enough sleep? When you ask, like, is there any sport? So if there is any sport, is he helping you to look after the baby? Have you able to get, enough sleep and regular intervals? Have you been able to eat and drink? And then she says, well, with the baby, it's really difficult, but I'm trying to when I get a chance. I will take that up and should say, okay, so yes, it's quite obviously it's understandable when the baby is not sleeping all that tiredness and that, but it's very important actually that you try to have some time for yourself to have regular meals and also plenty of water, particularly when you're breastfeeding as well, because sometimes just a simple reason like dehydration, lack of water in your body can lead to this that type of severe bad headache. So try to make sure you do get time to eat and drink. Then you ask about, yes, overall ask about any problems during the pregnancy. Did you have any high blood pressure during the pregnancy? Did you suffer with any headaches during pregnancy? Any headaches before? Any migraine you have ever been diagnosed? And then you will ask about any family history. of blood clots in legs and lungs, or any family history of high blood pressure with the loss of protein in the urine we call preeclampsia. Just ask that as well. Then ask about like how overall are you feeling. You know, I'm coming towards the mental health screening, so we'll say like, you know, so obviously it's quite overwhelming to have the baby first time and then tired and everything. So you're feeling, I mean, it's not unusual to feel when you're tired and hormonal changing in the body to feel low and depressed, and sometimes even hopeless. So are you having any of these type of mood changes? So that as well. And then we did ask about the partner anyway, is he helping and do you feel happy with that? Now think about neurological causes. The neurological causes will be about the vomiting, any flashing lights or any blurring of your vision, any pain in the upper part of the tummy. Have you noticed any loss of sensations or any, you know, funny movements in your body, in your arms or legs at all? Have you lost any consciousness, you know, till you started? So according to the role parent exam, basically, if you would have asked me this exam, this question, I would have told you that, well, I don't remember, but my husband says that I was, you know, a bit funny, a bit funny at some stage. And then we need to keep COVID in mind as well. This headache is one of the COVID signs as well. So we also need to make sure then any other body, you know, anybody else at home having headaches or any unusual flu-like symptoms or fever. You know, are you been exposed to anybody who's diagnosed with the COVID? So, you know, take this point as well now. Thanks to COVID now. So, and then you will, you know, ask about overall any history of infection, ask about even UTI, you know, any dysuria, have you noticed any pain or swelling in your legs? So just, you know, keep your one cause one by one, just work through it. Did you have any epidural during your labor? And was your, you know, you did ask about the delivery, was it straightforward or were there any problems? And then you start talking about this. So then you will say, okay, so I mean, we have done your blood pressure is within normal range, slightly towards the higher side of the normal range, but it is normal range. Your heartbeat is slightly faster, but that we will expect when you have the bad headache. Your urine shows us the signs that you're quite dehydrated. So it's very important that we replace your fluids in your body, and that might help. It might be just as simple that you have been dehydrated and you're tired, not able to take a sleep. So just correcting that might help you to improve your you know, headache. But then at the same time, now you're explaining to the women that if somebody has severe headache after the delivery, we like to observe them for some time to make sure there is no serious cause for it, because you know, the women can develop high blood pressure with the when they can start, you know, losing protein in the urine, one of very serious condition we call preeclampsia. They can also start presenting with a headache. And then sometimes there can be a blood clot in the one of the blood vessels in the brain. That may be a reason. And sometimes, very rarely, but sometimes there might be a small little bleed in the brain, which could be a reason. So for that reason, it's important that we do admit you and observe you for some time. So what we will do, you know, we're going to admit you. I will give you some fluids through the drip to correct your, you know, that dehydration. And then we will check your blood pressure after 4 hours again, and for any urine protein in the urine as well. And we will really encourage you to try to take some rest, you know, some uninterrupted rest for a few hours, you know, and maybe that just simple these things might help you to relieve your pain. No, then she says, I have a little baby and how I can. So baby mother unit is not for any postnatal. There is particular dedicated unit for women who have postnatal depression or psychosis or mental health illness. The baby mother unit is for them. This woman will be just admitted because she's in a lot of pain at the moment. We will admit her in one of the rooms in the labor ward. Basically, she needs close monitoring. So we will admit, and we can actually you know, encourage her to say that you can, you know, you're one of the family members can attend here as well and stay with the baby. And if you're breastfeeding, you can express the milk, which can be given to the baby through the bottle. But it's very important that you do get some uninterrupted few hours sleep. Yeah, asked about the epidural. If she had an epidural, then even this fluid replacement should help it. If she hasn't had, then obviously we don't need to worry about it. But if she had, then we can say if after these simple measures your headache did not improve, then I will call the anesthetist to come and have a look as well, because sometimes when you have, the epidural, there can be some leakage of your, water in the backbone, and that can also cause, but then you will obviously make sure when you say anything makes it better, like, sitting down and lying and standing, they should help you. And the next will be then, yes, after that, so I will send you some blood tests as well to check your normal cell of the blood and to check your liver and your kidney function and also the other salt levels in the body, and also clotting and bleeding capability of your blood. And hopefully, if you you improve with these simple measures, that's well and good. We'll send you home, and if not, then the next will be we will request our brain doctors. We call them neurologists to come down and have a look as well, just to assess if there could be any possible reasons related to that. And one of them, as I said, is the risk of blood clot in the one of the blood vessels or small bleeding. So, they will come down, assess you, and then if required, we also may request a special scan for the brain called MRI. That will also help us to get an idea. So, for that reason, it's important I admit you. And then ask how you feel about it. Will that be okay with you to get admitted or have all that stuff done? Yeah, always remember, don't forget just giving the plan. If it's a role player, involve your role player. After whatever the investigation, test, or management you are talking about, just ask her then how you feel about it. Will that be okay with you? Are you happy for us to go ahead with this? Okay, by asking these type of things. And yes, that's what you will do at the time moment. Any good question before we go to the next one?
And then where will be the baby, ma'am?
Where will be the baby? Baby, okay, so the baby, other important thing, I have noticed saying okay, the midwife and the staff will look after your baby. No, we don't have that much staff available, and midwives can't. So it's a relative. The one attendant can come with the baby. Baby can be at home. The breastfeeding, if there's a reason that the breastfeeding, the breast milk can be expressed and given in the bottle to the baby. And obviously, and we will, the reasoning we will start that is important, you get some uninterrupted sleep. And yeah, no pressure. If it's not, she needs admission, she needs admission. We won't just get because she wants the baby with her. We need to tell it's very important, otherwise, if it gets serious, then you might require a prolonged hospitalization.
If she doesn't agree, ma'am? No, I want
It's unlikely. If you have done all these serious risk and also told they can be life-threatening, and and that she doesn't agree. But if she doesn't agree, then that's all right. That's our a standard statement to respect patient's attorney will say, okay, I mean, we will strongly recommend you to get it admitted because it explained you. It could be something very serious, which can be life-threatening and it can even cause death. However, as long as you understand all these risks and the need and the importance of the monitoring, observation, and all these tests, if you still want to go ahead and go home, let me arrange some of these tests and a review by the consultant and the neurologist before we send home. Okay.
Madam, what is the obvious diagnosis? Ketone +3 with the BP normal and everything is there.
Dehydration. At this stage, it's only simple dehydration. So exclude any infections. That could be one of the reasons. But if she's afebrile and it's only the ketones and she's not diabetic, then it's just simply she's just dehydrated. It's not unusual for new moms to be honest to be dehydrated in first few days after, because they're just conscious, anxious about the baby, not eating, sleeping, no pattern, breastfeeding, all that stuff. Yeah.
So admissions were exactly in the ward or that maternal child unit, or where exactly we should admit her?
So there is nothing like maternal child unit. There is only baby mother unit, and baby mother unit is for, I have explained already, for mental illness patients. These patients, they will go to the postnatal ward, but that depends. If we are saying that we need to have a close monitoring, I mean, these women we can send, it's not important as long as you just say we will admit you. Okay, this woman is just for the headache. Postnatal ward, obviously there is less staff. They may not be able to basically to follow her for any worsening symptoms and also to check her blood pressure more frequently. So for the time being, we can admit if we have a free room, one of the side rooms and the delivery suite, we can admit there, do these initial, all these tests, send them off, and first if we feel they are, you know, satisfactory, then we can send her to the postnatal ward. But at this stage, I will admit this woman if we have a room available on the delivery suite at the bed in the bay. I'll keep here for the initial assessment. All right. Next.
Just one question. How can you repeat how you explain the epidural, that it's due to epidural?
How we explain the epidural?
That it's due to the epidural. It can be
Okay.
due to epidural.
Epidural tap, yeah. So we can say if she has an epidural, I will say because you have that, you know, epidural during the pain, you know, during for the pain and stuff. Sometimes there can be a small leakage of the water in the backbone into that space where the epidural is inserted, and that can actually cause the blood pressure fall down, and that may be a reason of headache as well.
Okay, ma'am. Thank you.
Leakage of water, yeah.
Thank you.
Who is next, Pramila?
Myself.
Okay. Give me 1 second. Right, that's the one for you.
Okay.
There's your first 2 minutes, Pramila. You can start.
Hello, good morning. I'm Dr. Pramila, the doctor in the labor room. May I know your name and age, please?
Yes, good morning, doctor. My name is Susanna Robert. Brother, I'm 26 years old.
How should I address you?
You can call me Susanna.
Okay. Susanna, actually, I see that this is your second pregnancy and you had a previous normal vaginal delivery and you have come today with pain. Just now for last 2 hours you are having pain. Is that okay?
Yes, I'm having some contractions with kind of tightenings, really.
Okay.
But they have almost stopped now.
Okay. Okay. And was there any associated leaking of fluid down below?
No, I didn't notice any water leakage. No.
Any bleeding?
No.
Are you appreciating the baby's movement?
Yeah, pretty good. Yeah.
Okay. And I also see that your baby was actually in the bottom down position earlier, and we had done we had tried to turn the baby into head down position, and we were successful at that time. Yeah.
Yeah.
And the midwife has just examined you. Did she tell you anything regarding the examination finding?
Yes, she has. She, she told me the baby has turned back to bottom down position. And that's why she said, like, I need to consider about how I want to deliver, like cesarean section or something. But I'm really looking forward to have a vaginal birth.
Yeah, I understand
so
your.
Yeah.
Yeah, I understand that you want to. You're very keen on vaginal birth. And it's not sometimes this happens even though we are successful in turning the baby into head down position, a few number of babies might turn back into bottom down position. So in that situation we have got different options are available, but before I discuss with you the different options available and the advantages and disadvantages of each of them, is it okay if I ask you some questions so that I can tell you the better options?
Yes, doctor, absolutely fine.
Okay. So how was this pregnancy so far? Was there any complications so far?
No, I didn't have any problems at all whatsoever.
Okay.
Other than
So
obviously the baby is just in this position.
Yeah. So all the scans, everything is normal?
Yeah.
Yeah. Okay. And do you have any idea how much was the baby weight when you did the last scan?
I was told that the baby's weight at that stage was like about 2.5 to 3 kg, 2.5 kg about.
Okay. Okay. And regarding your previous birth, was it a normal, uneventful delivery?
Yeah, it was normal, very straightforward. Yeah.
Okay. How much was the baby weight at that time?
The baby was like about 6 pounds.
Okay, around 3 kg. So you have delivered a average size baby, good size baby previously. And regarding the post-delivery period, at that time, did you have any complications?
No, I didn't have any problems.
Okay. And are you on any medications in this pregnancy other than the usual vitamin tablets?
No, doctor.
Okay. Do you have any other long-standing diseases?
No.
Any allergy to any medication?
I'm not aware of any, doctor.
Okay, that's good. And have you undergone any previous surgeries in your tummy?
I did have my appendix removed when I was quite young.
Was it an open surgery or a laparoscopic surgery or keyhole surgery?
Yeah, it was keyhole.
Keyhole, okay. And how much is your height-weight ratio?
It was like 25.
25, okay, that's good. And anyone in your family or yourself has got a previous history of any clot formation in legs and lungs?
You mean blood clots? No.
Yes. Okay. And how are you feeling nowadays? It's not unusual for pregnant females to feel sometimes little low in mood. Have you felt anything like that recently?
No, doctor. I've been okay.
And what do you do for living?
I work in the shop.
Okay. And do you live with your partner?
Yes, I do.
And is he supportive? Are you happy with him?
Yes.
Okay. Do you smoke, use alcohol or anything?
No, doctor, I'm not drinking or smoking in my pregnancy.
Okay, that's good. So regarding the options you have got, actually there are 3 options you can consider. One is we can try to do the same procedure which we did earlier 2 weeks back. That is what we call as ECV. That is turning baby back into the head down position. So that is one thing that we can try. The only thing is, how was it the earlier when we did it 2 weeks back? Was it a very easy procedure? Did you have any discomfort during that time?
Yeah, it was uncomfortable, but the consultant managed to do it, you know, in second attempt, and it went pretty good.
Okay, okay. So this time also we can try that, but the only thing is that by in these 2 weeks, actually the baby would have gained a little more weight and the fluid around the baby would have slightly reduced. So it might not be as easy as we did in the 2 weeks before, but still we can try that. I will be, if you are keen on that, I will be informing my consultant and the consultant will be doing the procedure as he did the last time, and you will be given, if needed, especially if these contractions are there, you will be given some relaxants for the womb to relax so that we can do it easier, so that we can try. But
so will that be like, I know it's a bit uncomfortable last time as well, so will it be particularly painful this time?
No, it's not going to be too much painful, but to make the uterus womb little relaxed so that it will be easier for us to turn the baby, we will use some relaxants. But other than that, it will be as much the discomfort which you had last time, that much only this time you will be having. But we might not be able to do it as easy as last time. We might sometimes have to abandon it because if the fluid has decreased, we might not be able to turn the baby properly. So, and like the last time we told you, there can be complications. Just you would have been already told about those complications. You have to anticipate, like when we are doing this, sometimes this membrane can rupture and the fluid can start leaking. When we are trying to rotate, the baby might develop some distress. Fetal heart might drop down. Sometimes that after birth can separate. So all these complications would have been already explained to you last time. So the same complications might be there, and at any time you might have to be taken up for a emergency cesarean section. So how do you feel about that?
Yeah, no, that's fine. I'm happy to take that risk.
Okay, so I will inform my consultant and we will proceed accordingly. Meanwhile, I would also like to discuss with you, suppose this procedure doesn't become successful, because there's a because since now the fluid has reduced, as I told, it might not be always successful. So if it doesn't become successful, then you have got 2 other options available. One is you can try for vaginally delivering this baby as breech itself, that is bottom down itself you can try to deliver, since you have already delivered once vaginally. The other option is to go for cesarean section without trying for that. So so regarding this vaginal delivery, the advantage is like we can avoid anesthesia, we can avoid the problems of any surgery. You will be up and about earlier, you can go home early, you can go back to your baby early. And you are you planning on a larger family?
I mean, this is my second baby. Yeah, I would like to have more children. Yeah.
So if you like to have more children, again, avoiding a cesarean section would be good. But the only thing is that while we are delivering your baby, there could be complications, especially when with regard to the delivery of the head. So before if you are keeping your for vaginal delivery, we will be doing a scan once again to see the weight of the baby. If the baby weight is more than 3.8 kg, we don't usually keep the baby for vaginal delivery. Also, we will be looking at the lighter and the position of the baby, how the baby, whether it has changed now, how the baby's head is. So all these things we will consider. And if all factors are okay, we can try for a vaginal delivery. But the only problem is while delivering the head, there might be problems can arise, because usually when the head is coming down first, head gets a lot of time to get itself adjusted to your pelvis and its shape adjust to the pelvis. But here the head is coming for the first time into the pelvis after the remaining baby has delivered. So it might not be able to sometime adjust to that shape, and there might be problems in the delivery. But we are anticipating those complications. So a person who is well experienced would be conducting this, and we'll be keeping everything ready for a cesarean section if any complications arises.
Yeah, okay.
Okay.
Yeah.
Yeah. Another option is you can, if you don't want to go through this risk of the problem with the delivery of the head, you can always think about going for a cesarean section if this procedure doesn't become successful. So the advantage is that this the problems happening to the baby's head, the problem with the delivery of the baby which can happen can be avoided. But at the same time, doing a surgery can have its own complications. You might have more pain. You are moving around might be limited. You have more chance of clot formation in legs and lungs, and it will take few days to go back home and get back to your normal activities. And not only that, in the future pregnancies, there is a chance.
Time is over, Pramila.
Okay.
Okay. Right. Okay. It was good. It was pretty good. The only thing I felt was I kind of felt like I wasn't like involved. I was just getting the information. You need to, once you explain one thing, you need to ask how you feel about it, what you want to do. Just involve the patient in between as well, other than obviously checking her understanding. The rest was fine. Yes, absolutely okay. Just take obviously a bit of background information, any complications and risk in the pregnancy, how was the previous pregnancy, how was the previous ECV, how easy or difficult it was. And then, yes, we need to establish what is pattern of her contractions. Now, I just said like they have gone, or if you might say they're gone, or if they want you to talk about ECV, or they are just very irregular now. And then, yes, make sure the membranes are still intact, any bleeding. Is she happy with the baby movements? Check the CTG. You will say, so I'm just going to have a look on the CTG. Have the midwife, did the hot trace of the baby or not yet? And if not, just say, I'm going to ask her to make that. So we'll just make sure the baby is, good and happy. And then coming to the options, yes, these will be the three options. The one will be to try to turn this baby around again. However, yes, explain the chances of that success will be comparatively low as compared to the first attempt, because there's less space available around the baby now, and baby has grown up than before. And obviously the chances of rupture of membrane during that, or separation of the afterbirth, the cord entanglement can be slightly higher than before as well. So you can just tell yes further regarding we can give you we will give you some medicine which will make your muscle, the womb muscle go a bit more relaxed, so that we can get a little bit of more flexibility of the womb to rotate your baby around. We will be ready. You need to tell about the chance of going for emergency cesarean section to say, like, if we have any concerns, like if we have any suspicion the part of afterbirth might have separated, or you start bleeding, or the baby heart go very down and didn't recover, then we may need to proceed direct to the emergency cesarean section. So that is something you will really need to keep in mind before we go ahead with this procedure. And then ask her how you feel about that. Is it something you feel you will consider? And if she says, then you say, okay, so I'll just let me just inform you of the two options as well, and then I will just speak to my consultant and check. At this stage, I mean, yes, it is to be done by the consultant, but we're not sure whether the consultant actually will be happy to do and will be doing or not. So I won't promise to say the consultant will come and do. I would rather say I will speak to the consultant. And if she or he, feels it's okay to go ahead to try the ECV, then she'll come down to do this for you. And then the second option is obviously to have a cesarean section to deliver the baby through the cesarean section, and then just give a very brief idea about, there will be anesthesia required that will be given in the backbone to make you numb from, from your waist below, and then, we will open the tummy just from the lower part of your tummy, and then open the womb and deliver this baby. When the babies are in this bottom down position, their delivery can be slightly complicated as compared to the head down babies, because we need to do specific maneuvers to deliver the baby, because the baby's bottom and the legs can be delivered easily, but then the baby's shoulder and head can get stuck. So that does require some maneuvers. In an attempt to those maneuvers, there can be slight increased risk of the cesarean wounds to get extended, a little bit of more bleeding. However, we are aware of these and we will take care of this. So that's about the cesarean. Now the cesarean obviously will require a bit more longer hospital stay after. You will need a the catheter, and you will be staying here for 3-4 days if everything goes straightforward. And there is a slight risk of injury to bladder bowel and to the water pipe during that operation. And then we will assess you for the risk of any blood clots, and then we'll give you some blood thinning medication and appropriate pain relief. So that's a bit about idea about the cesarean. Then you tell about the vaginal birth. So the vaginal birth, you will say, okay, so the vaginal birth obviously is a very good option for the mother, as you had that before already. You understand is, if it goes smooth and straightforward, you're up and about straight away after the delivery, you're mobile, you're able to look after your baby, you will be able to go back home within few hours and look after your other child as well. However, the vaginal birth of the babies with the bottom down can be slightly high risk for the baby's point of view. Because when we have a head down during the process of labor, slowly when the head is coming down into the bone, then the baby's head actually, kind of gets slightly shaped into a position, sometimes a little bit of, sliding down of the bones of the baby to make it appropriate size to pass through the bone, the pelvic bone. However, when the baby is bottom down, then obviously the bottom portion part of the baby's body is slightly narrow as compared to head, so that can get delivered easily. There can be actually slight risk of the baby's cord might be coming down if the water's ruptured during the process of labor, because just it's a narrow part, it's not fixing very well in the lower part. But obviously, we will be keeping an eye on that. We will be monitoring baby's heart continuously, and we will examine you as well to make sure this is not happening. And then at the time of birth, again, we will need to do the specific maneuvers to deliver the baby's shoulder and the head. So there can be a risk of shoulder, and then the head might be a bit more tricky to deliver through vagina as compared to cesarean section. Because there won't be enough time for the head and the bones to actually get the position and get into, closer to each other to adjust the size of the bone to come out. So that can delay sometime the delivery of the head of the baby, and that can result in lack of some blood flow and oxygen to the brain. However, this delivery will be done by the trained clinician, like by the consultant. And hopefully most of the time the vaginal deliveries of the breech babies go very smooth and straightforward, but these are few risks you need to keep in mind. And after then you need to ask her, so how you feel about this, what would you like us to do, or what would you like to go ahead. Yeah, and then you just do it accordingly and just say to her, okay, I'm going to do that accordingly. If she says the ECV she wants to try, then you can say, okay, so I go and inform the consultant. I'm going to leave you this written information. I know you have this procedure already, but still I would like you to go over it again. So that if you have any questions, you can ask me. And I'm going to bring the consent form as well, so we can get it signed. If she says cesarean section, say the same kind of thing. If she goes for vaginal birth, then you will say, okay, so I'm just going to speak to the consultants and inform about your decision. And then I will document all this discussion, which we have done into your notes. Any questions? Okay, seems like everybody's happy. Let's go to the next one. Who is next?
Lubna.
Okay, Lubna.
And so where could I have cut short actually to adjust the time?
Ma'am, is it necessary to ask smoking, alcohol, recreational drugs questions in this scenario?
Yeah, so that's the history bit. You can shorten a bit at this stage because she's like more of active management at this stage about this particular scenario. I wouldn't worry about the detailed antenatal history. I will just ask a few questions about her BMI. The weight of the baby was a good question to ask. And then about, because if she, yeah, just any maternal complications, whether any problem or any with the baby, and sometimes you can even say, so if you have that, this done already, am I right to assume that you don't have any complications and problems with this pregnancy yourself and the baby, and that's why they went ahead with the external cephalic barrier? Yeah, so don't need to go into that detailed antenatal history, and that's the only part where you can obviously save your time. Okay, who was the next? Sorry, again.
Lubna.
Lubna. Are you with us, Lubna?
Then next is Sapna. If Lubna is not there, Sapna.
Sapna is there?
Yes.
Hello.
Okay. Hello. Yes, Sapna.
Yeah.
Okay, Sapna. So let me see which one is yours. We have done this already. Okay, so this is for you.
Okay.
Okay, you can start.
Hello, I'm Dr. Sapna, one of the doctors in the postnatal ward. May you please confirm your name and age?
Yes, doctor. My name is Laura Thomas, and I'm 30 years old.
Okay, so how would you like me to address you?
You can call me Laura.
Okay. So Laura, I can see from the notes that you are on your postnatal day. You are on your second postnatal day, and your baby was admitted in the NIC in the baby unit, and is presently discharged. And you had some concerns, so the midwife has asked me to see you. So could you please tell me your concerns, Laura?
Yes, doctor. My baby was born quite unwell. He wasn't breathing properly, and so they had to admit him to the baby unit. And I'm really worried about my baby. And you know, I mean, it's all my fault that, you know, I wasn't pushing well. And that's why I ended up having this delivery with the forceps. I mean, if I would have pushed well, then, you know, I could deliver the baby and my poor baby wouldn't have to go through this all. You know, I'm really, I'm so worried. And I'm feeling so bad and guilty about it.
Laura, I can see that you're really upset, but let me tell you one thing, that most of the mothers, pregnancy is not an easy journey, and going through a delivery is a difficult one. So it's very common for all the women to get exhausted and tired. And sometimes it happens that we may have to help you out to deliver the baby because of various reasons. So it's not very uncommon. It's not, I just want to tell you that it's not because of something that you have done or you haven't done that your baby had to be admitted in the baby unit. And presently your baby is fine. So I think I can see that you are feeling really low, but I need to reassure you that you are not the reason for this. Do you get me, Laura?
Yeah, but you know, I mean, I don't know. I mean, you might just end up with this problem for whole of her life, and you know, I don't know. I mean, I have been really worried.
Okay.
I could have done better. I could have done better.
Don't worry, Laura. We are here as a team to support you. Okay.
Yeah.
So before we discuss with you more, shall I ask you a few questions so that I can help you in a better way?
Yes, please. Yeah.
Okay. So presently, Laura, how are you feeling? I mean, do you have any bleeding or any foul smelling discharge? Any complaints at present?
No, I mean, I have a bleeding, but just I guess just the normal is not much. No,
Okay.
I don't have any smell to discharge or anything.
Okay. And how's your water births and bowel births?
Yes, I have opened my bowel this morning.
Okay. So that's really good. And is your baby latching well since the discharge from the baby unit? Okay.
Yeah, I mean,
And
yes, the baby is with me, and you know, I'm really worried. You know, that what if she has problem with the breathing again? So, you know, I can't leave the baby alone, and I can't, you know, and I'm not sleeping because I'm worried that if I sleep and the baby stop breathing, then what's gonna happen?
Laura, it's really common for women to have these kinds of thoughts, especially in the immediate delivery period due to the hormonal fluctuations. So we are here to help you in whatever way we can. Okay.
Okay.
I understand that this is your first pregnancy, and how has this pregnancy been so far? I mean, did you have any problems during your periods, during your pregnancy, like feeling of, feeling low or any mood changes?
I mean, it's been difficult because I'm on my own in this country. So I had been feeling obviously quite anxious, and this is my first pregnancy as well. Throughout, but I didn't think it's gonna be that difficult.
Okay. Did you have any other problems like raised blood sugars or raised blood pressure or anything of that kind?
No, I didn't have any problems like that.
Okay. Other than this, have you been following GP for any other medical conditions?
No, I'm not seeing GP for anything.
Have you undergone any surgery in the past?
No.
Okay. Any history of drug allergy?
No, as far I'm aware of, no.
Okay. Is there anything of specific concern in the family, like feeling of these kind of feelings when your mother was pregnant, or have you ever heard of them talking about this? or your sisters feeling the same?
I don't have a sister, and I don't know anything about my mom because I mean she never talked anything like that. I mean, I don't know.
Okay. Okay. So, what about your partner?
My partner is not here. He's still back home.
Okay. So, just to ask you whether your partner, how was his thinking about this pregnancy? What were his thoughts?
I knew about this pregnancy when I had already come in this country. I would have been about 6 weeks pregnant then when I did the pregnancy test. He was happy. He was very happy and excited, and obviously he tried. We tried that he can also come over before the birth of the baby, but he's not able to come down yet.
Okay. Have you talked to the partner after the delivery?
Yes, I had to talk to him on the phone this morning.
Okay. So, is he planning to come?
No, his papers are rejected again, and he was
Okay.
when I told about the baby, he was very worried as well.
Okay. So, Laura, I just need to examine you in the presence of chaperone to see your general condition, if everything is fine, and also your tummy to see if your womb has started, becoming contracted. It's still contracted, and also local examination to see from down below to see if there is any abnormal discharge, and you're not having any fever or any other problems of that kind, right?
No, doctor.
Okay. So, since I know that you are feeling very low, we have trained professionals like the counselors who can provide you with adequate support, and so I can put you in touch with the counselor. How does it sound, Laura?
Yeah, I think that would be helpful.
Okay, and as I said earlier, it's not very unusual for women who have delivered to, especially without adequate support, to feel very low, especially when the baby is baby was admitted in the baby unit. So I'd like to put you in touch with the perinatal mental health team as well, to see if you require any medications to help you with your mood. Okay.
Yeah, that's
Now,
fine, doctor.
okay, and also to make sure that your baby is fine, I'll also have a word with the baby doctor to see if everything is fine with the baby, and if the baby can be with you all the time, so that you feel happy and reassured. So I'll ensure that also.
Okay, doctor.
And I can arrange a consultation and appointment with the baby doctor as well, so that you might feel better once you get an overall idea of how the baby's health is like, and what
Yeah.
all things you have to take care regarding your baby's health. Okay, and your feeding.
All right. Okay.
Okay, and if you find any difficulty during your breastfeeding, we can put you in touch with the breastfeeding specialist as well to see that the baby is latching well. All right.
Okay. Time is over. Yeah.
Okay. Any more concerns?
No, that's fine, doctor.
Okay. Okay. Thank you, Laura.
Yeah, thank you, Sapna.
Sorry.
Good.
Actually, I didn't know how to take the station.
No, that was pretty good. Just like as we said for all the antenatal women, we must ask 3 screening questions about the mental health and mental domestic violence and stuff. For our postnatal women, then we also must exclude the postnatal depression, even if that is not a presenting complaint. Yeah, so it should be very usual question to all postnatal women to ask. Just the way we phrase it, like it's not unusual to feel low because of this, and are you particularly feeling low in your mood or tired? But obviously, when you read a scenario that there is some difficult delivery, maybe in the baby unit, and particularly if they have some problem like some abnormality as well. Obviously, these are the people who are at high risk of having this, right? Now, this one I just kept simple. It's just like the baby went to the baby unit for some respiratory problem because of instrumental delivery, whatever, and now the baby is fine and back. And there is a clear, I've told as well, like she's in a low mood and anxious. So you know you need to focus on mental health and postnatal depression kind of thing. But sometimes it may not be very clear. It all might say the baby is, admitted with this complication. Like there is a question about tracheoesophageal fistula, which comes quite frequent as well. That the baby is there and she's quite upset actually by saying why you didn't pick up at right time. Huh. What's the joy? I don't know, my laptop is pretty temperamental today. It's just doing things and it's what it want to do, honestly. Yeah. So where were we? Okay, whatever. Right, so in those ones, it might not be the way she start will be like maybe the midwife come and say to you that she's quite upset and unhappy that why we didn't actually diagnose that congenital anomaly or whatever during the screening. And that is very similar question like this, that, the scenario which I remember is the same way the woman is asylum seeker and coming, and then the baby is with tracheoesophageal fistula in the neonatal ward, and the woman is unhappy to say, I was being called to have frequent scans being done because I had more water around the baby than usual. And they kept telling me everything is okay, but when the baby was born, the baby was not feeding, and then they told me there is a connection between baby's windpipe and the baby's food pipe. So why that happened? Why, so apparently when you start, you might feel it's about an angry patient. So you will, and it is about angry patient as well. And she's threatening to put a complaint in. So in those cases, it's particularly, the risk that you might actually miss to do the detailed assessment for postnatal depression point of view. Because you just overwhelmed explaining the patient what that was, why it can be missed, and then she's asking, worried about how that will be done, and also always make sure you do touch that question by asking. I can see this is quite difficult for you, that the baby has, quite unexpected for you as well. So and you're feeling angry about it as well. And obviously, it's not unusual under such circumstances to start feeling anxious, low in mood, and sometimes, some women can feel so low and depressed in their mood, they might start having some feeling of, disappointment to the level that they start thinking, they might start having the thoughts of self-harm or harm to the baby. So have you been experiencing any such type of thoughts? So you need to ask. And this one, it was anyway clear. We said this woman was low mood or whatever. So to start with, yes, first of all, give her reassurance if she's self-blaming. No, there's nothing particularly you have done wrong, and it's not necessarily always because you were tired and you couldn't push. Sometimes the baby is, the head hasn't quite come down, but the position may be in such a way that, this is not uncommon for the woman to get assistance. They need assistance to deliver the baby. And it's absolutely okay. Yeah, so this is how we will reassure. So I wouldn't say that we do, because what she's feeling, that we give them assistance. She's feeling I couldn't do it, so I need to normalize it for her. Many other women need that assistance as well. This is quite common. And as long as the baby is okay, it shouldn't be, some thought of worry for you. And then, yes, this baby ended up of being over there, and you can say, so when the babies particularly need that assistance to be delivered, again, it's not unusual that for the time being when the babies are born, they might feel some difficulty in breathing. And that's not uncommon either, that we then take these babies and keep there just for close observation. It doesn't necessarily mean there was something seriously wrong with the baby. So sometimes we want to make sure, yes, they're breathing normal, that everything is fine and happy, and then we bring back it to you. And then you can ask her, So have you been told anything by the doctors, pediatricians? What have they told you? Was that just like a temporary difficulty in breathing baby has at the time of delivery, or they particularly told you is something wrong with the baby? So just establish that as well. And then after that initial one, reassure her to say, okay, so you're the baby with you. Are you able to feed the baby? Are you breastfeeding? Are you feeling the bonding with the baby? And how is baby doing? Is baby quite active? And after that, you can then ask about for her immediate well-being after the stitches, obviously, she had. So just ask about, so tell me about your bleeding down there. Are you bleeding quite heavily? Any pain down there? Obviously, it can be painful. Do you have any stitches? Is there any pain? Are they giving you pain relief regularly? Have you been open your bowels and bladder? Are you eating and drinking? Very important here to ask her. Have you been able to eat and drink? Have you had something to eat this morning? And then she's repeatedly saying, I'm not sleeping. I can't sleep because I'm worried about the baby. If I sleep, what if anything goes wrong with the baby, and all that stuff. Then we need to say that, I understand you're quite, anxious because obviously the baby initially had that problem. But let me reassure you that, as I said, like sometimes the babies do that. That just is a temporary. And once the baby has recovered from that and breathing normal and happy, this baby is at no additional risk that this baby will develop that problem. Okay, so it's just like you need to just look after as any other mother will look after the baby. Okay, so try to enjoy this time with your baby. Then you can say, you can then further establish by saying that, if you feel really, that much stressed and low in mood, what I can do, if that's okay with you, I can call our, the specialist team, look after the mothers, particularly these type of mood changes after the delivery. We call them perinatal mental health team. And they can actually provide you some support with that. Sometimes it's just the explanation and counseling and support you need, and you're okay actually to deal with your, you look after your baby and yourself and go home. And sometimes you may need a little bit more help. Sometimes they might put you on some medication, and then we may then decide to keep you on our baby mother unit as well for a few more days. And then just ask about those red flag symptoms, which I just told you initially, that, ask about, like sometimes they feel so low and they're depressed, they might start having these thoughts. So the red flag symptom screening is very important in this woman, particularly saying it's my fault, I shouldn't have done that. And my baby and my partner is worried and all that stuff. Then the second important thing we need to check with this woman is that there was a whole part of, actually one part of the this station is to check the sport and accommodation issues. So just ask about, so she said there's nobody from the family. Okay, do you have any other family members or friends around here? What type of sport you have? Then she will tell you, I'm living in an asylum accommodation. Then you can say, okay, so what we are going to do then, we will try to contact the social services, and then we can see if we can actually arrange some sport for you, like some sport worker who can help you and your baby to look after. And then we can also, she will, that sport worker can also try to arrange some independent accommodation for you on priority basis, because you got a baby now as well with you. So how you feel about that? So just ask that as well. It's very important. And then yes, and then the closing will be to say that I'm just going to speak to my consultant as well, and then I'm going to ring and we will request one of those practitioners to come down and assess you. And then because of her condition, and she is just asylum accommodation and stuff, this lady obviously postnatal ward for a day or so, and then after that I will really keep this woman on a mother baby unit for at least minimum a week to see which way she goes before we send her home. Right, quick question.
In the postpartum scenarios, do we really have to touch the contraception options also?
That depends on what type of scenario that is. Yeah, so if this type of scenario where there is an acute problem immediately after the birth, then we need to address those issues first, and we are keeping her in. So even if you don't get the chance to speak any contraception, then there won't be any I guess the marks. However, if there is something that we are planning to discharge her, then we need to address about the contraception. So we will say, like, we will start you on some safe and effective contraceptive method before we send you home. This lady, we are not actually starting to think about the discharge plan. Yeah, all we need for this one is to do the assessment at this stage. Okay, is there any template to follow for these type of questions? Rania, this is like, so what I have spoken and told you, that's the template, darling. So when you will listen to the recordings, you need to take your own bullet points.
Ma'am, when somebody says they can't sleep, can we prescribe some sleeping pills or some anti-anxietic medication for the time being?
Okay. Yes. So yes, there has been a scenario as well coming in where the woman says, and particularly she's asking, I haven't been able to sleep last night at all, and can you give me some pain, some sleeping pill? Yes. So again, we need to do the mental health assessment for her sport, counseling, speak to perinatal team and ask them to come and review. And then yes, it's not unusual, to write down one of something for one night sleep. Yeah.
Dr. Safia, please, could you just summarize what shall I tell the patient in main point or management of this patient?
The one we have talked about, just to discuss, yeah? What's wrong with me?
What I mean, the main point in management, like I will be admitting you, or the mother will be on it, or just main points.
Yeah, give me 1 second. When I want to enlarge or squeeze this screen, it doesn't do, and then after that it just jump to wherever it wants to. If you give me 1 second, let me get to the station. Okay, so for this woman, yes, I will go introduce myself, and then I will say, yeah, so I will just say to her, hi, Laura, blah, blah, and then we'll say, okay, so the midwife, I'm not going to summarize anything here, basically, because when it's about like the patient has the concerns, I want to discuss something, it's better just introduce yourself and give an open question to invite them to talk to you. So I will say, so the midwife has told me that you have some concern, that you're worried about your baby. So would you like to tell me what is bothering you? And then let her speak whatever she says. So then she tells you about that I'm not able to deliver and I couldn't push or whatever, and then the baby ended up there and that's all my fault. Then first of all, you need to acknowledge and you say, I can see it's quite distressing for you, and you have found it quite upsetting, and you're very worried about your baby. So is baby with you now? So unless you see she's sitting with the baby, otherwise that's, is baby with you now? And then and how is baby doing? And then the first we start actually to counsel her, we need to also establish how the baby is doing. So then we will say, okay, so when the baby, how long baby was kept on the baby unit, and has the baby doctors told you that they were just a temporary, and the baby is fine and recovered and there's no ongoing worries. Then you can say, again, acknowledge, say, it's not unusual to feel like this after this. However, let me explain you that it's not your fault, and it's not necessarily that you are tired and you couldn't push hard. So I would strongly encourage you not to blame yourself. Sometimes it may be the position of the baby's head, or maybe the baby's head hasn't come that down where a baby can deliver spontaneously. And for these various reasons, it's not uncommon for many women to get the assistance for the baby to be delivered just at last minute. I mean, you have taken the whole labor yourself. You did very well. So it's okay, and as long as the baby is fine and doing well now, you don't really need to worry about it. And then start by saying, okay, so have you been feeding your baby? Are you breastfeeding? Any difficulty in your breastfeeding? And how is your bonding? How you feel your bonding with the baby? And then you can just simply ask about, overall how she has been since the delivery, able to, as like any stitches down there, do you have any pain, have you been able to open your bladder and bowel, ask about eating and drinking, ask about sleep, then ask about other sport available, and then she tells you about that she's in asylum, ask about, I wouldn't go too much of details of the partner has been able to come down or not, but it's enough the information she gave that partner is still trying and is not here. The important question will be for me to say, so have you, made some friends over here, then have you, what type of sport you have around you, and then listen what she says, and if she says she isn't, then obviously we need to take that point and note that she will require some support afterwards as well. Then I'm going to do her mental health assessment. So you can just ask a couple of questions about the pregnancy. Is there any other problems at all? Do you feel particularly anxious or low in your mood during the pregnancy? Yeah, because it may be common for her, that she was actually in antenatal period as well, being alone and all that stuff. So that will be important question to ask. So you can ask that one. And then if she still keep bringing the baby, then sometime it's good to ask them, okay, so tell me what particularly you're worried about your baby. All right, so think what she's saying, and if she still says like, if I sleep and this baby might stop breathing and stuff, then you can reassure again by saying, have doctors told you anything that the baby has any ongoing problem with the breathing? And if not, then I will say, so I will also check the baby's notes and speak to baby doctors. And if they haven't mentioned, it's not uncommon, the babies who need some assistance to deliver, they can have some temporary problem immediately with the breathing immediately after the birth. And so that's why we take them to the baby unit to just observe them more closely to make sure everything is okay with them. That doesn't necessarily mean they had something wrong with them, right? So as long as if the baby doctors have told you baby is fine, there's no ongoing issues, then you don't need to worry about that. This baby does not have any additional risk of having any problem in bleeding or stop breathing than any other baby. So you just need to feel normal like any other woman, and try to just spend time with your baby and enjoy this time with your baby. And then go towards more serious red flag screening to ask about, then, I understand you have difficult and there's no sport around as well. So it's not unusual for the women to feel quite low after, being tired and all that, going through anxiety. And some can feel so, low and depressed and disappointed that they might start having the thoughts of self-harm or even harm to the baby. Have you been having any such type of thoughts at all? So just very nice and clear question. And then you will say, so, now I can see because you're struggling with your mood. So what I'm going to do, I'm going to discuss with my consultant, and then I'm going to speak to our specialist team who deals with the, these mood-related problems with the of the women during the pregnancy and after delivery. We call them perimental health team. So I will request one of their practitioners to come down and review you, and then they will sometime it may just be some support and counseling and explanation of the events that might help you just to start feeling normal again. If not, then sometime they may start you on some mood elevation medicine. They will explain you that all in detail if required. So now, considering that you haven't had the much support around you and you're feeling quite anxious about the baby, how you feel about if we keep you on our baby mother unit for at least 3-4 days to see how you go, and if you need any ongoing support with that, then once we're happy you are quite okay now, feeling normal in your mood, are you happy to look after your baby independently, then we will arrange your discharge. I'm also going to speak to the social services again, if that's okay with you, to find some support for you. Maybe it would be a good idea if we can arrange some support worker to help you when you go home with your routine activities to look after yourself and your baby. And they can also then try to arrange some independent accommodation for you because you have a baby now as well, and we can request that to be put on the priority list. and then yes, just say, ask how you feel about it, and then just go and say, okay, so you know, if you feel any further questions and anything, please let the midwife know, and I'll come back. And I go now and inform the consultant, and is that what you wanted?
Yes, exactly, Dr. Sophia. Thank you. I think about written information here in no rule. I can't tell her I will be giving you any written information because it's not clear right now.
I can't see the name. Who is talking?
Sama.
Sama. Yeah, that's fine. Right then.
Thank you.
You're welcome. Right, who is next, Pramila?
Deepthi.
Dipti. Yes, hello, Dipti. Are you with us? Say yes, sir.
If not, then Rabab has joined. She can take.
Okay, Rabab, are you with us now then?
Hello, Dr. Safia. Yes.
Hello. Okay. Why I'm showing this here? I've managed to shuffle all the slides up and down around. I don't know where I am now. Oh dear. We've done this. We've done this. Right, this is for you, Rabab.
Okay. Yes, doctor, can you push it to the left side because I cannot see the right side?
That's what I'm trying. It's not going that way. I'm sorry. My this laptop is very silly today. Okay, so this is like Rebecca Wood. She's 33 years old, 3 months postpartum. She's sent by her GP, who was unable to take the cervical smear for Rebecca because Rebecca could not tolerate the spectrum examination. She found it painful. So then the GP has given you some background, or there is just some background information that Rebecca had prolonged labor with force of delivery. She had an episiotomy, but on the examination by GP, it says the episiotomy scar is well healed. So there's no tenderness or any hypertrophy of the scar. Okay, your first 2 minutes start now.
Okay. Okay. Hello, I'm Dr. Rabab, one of the doctors on duty today. May I confirm your name and age, please?
Yes, doctor, my name is Rebecca Birch and I'm 33 years old.
How you want me to call you?
You can call me Rebecca.
Okay. I understood that you delivered 3 months back and you came today because there is some difficulty at your examination from down below. Is this correct?
That's right, doctor. I just could not have that examination and it was so painful.
Yeah, sorry for what you are going through. Help is available. So how you are doing after delivery?
I'm doing okay. I'm doing all right. I mean, it's just like, when the doctor wanted to put the speculum for the smear, it was just very painful. It just couldn't do that.
Okay. Okay, no worries. How is your baby doing?
Baby is doing fantastic. Yeah.
Did you call him?
Sorry?
What you call him?
He's called William.
Okay, nice name. So can you tell me more about breastfeeding?
Yes, I have been breastfeeding. I mean, it's not complete breastfeeding. I have some. I adapted the bottle feed as well. But it's going well.
Yeah. Okay. Good. And what about you have any problem from down below, like redness in your from down below?
No, I haven't noticed any problems, doctor. I had the cut down there, which was staged, and I feel that's healed properly because I haven't felt any pain, when I clean myself down there by touching it. But I don't know what happened during that examination. I just couldn't tolerate it.
No worries. I will provide you the needed treatment for your condition. Did you ever had any sex after delivery?
So that's another thing, doctor, I'm really worried about because I felt the same. I mean, when a couple of times we tried to have sex, so I actually haven't been able to, have sex penetration since delivery.
Yeah. Sorry for what you are going, but no penetration at all.
No, we just couldn't. It just found it so painful.
Okay. Do you have any problem at your water work?
No, I haven't noticed any problems.
Any problem at your bowel work?
No, that's been fine.
And can you tell me more about your period?
So I just had my first period a couple of weeks ago since delivery, and that was okay. There was very light bleeding though, but I bled about like 4 days.
Okay. Can you tell me more about your delivery?
So my delivery, my labor and whole was quite, long. It took a few hours, and then baby wasn't coming down, so they needed to do the forceps delivery, and that's why I had a chair down there as well, which was staged.
Yeah. And what was the baby weight?
Baby weight was about just above 6 pounds.
Yeah. Okay. And did you recover well from the episiotomy?
Yes, so like I didn't have any problems with that. I just tried to touch that area as well to see if that's what was causing the, caused the pain, but it's not.
Okay. Otherwise, you are fit and well?
Yes, I am, yeah.
Did you have any surgeries before?
No.
And do you have any allergy to any medicine?
I have allergies to metronidazole.
Okay. I will document this in your file and will make sure that you will not have this medicine in the future.
Okay, thank you.
Thank you. Are you on other special medicine?
No, I'm not taking any medicine otherwise.
Okay. Do you smoke?
No.
Do you drink alcohol?
Yes, I do, but not much, just small amounts.
Okay. Do you think of quitting alcohol drinking?
I don't drink much anyway, doctor. I just, kind of very small amount.
Okay. Do you use any recreational drugs?
No.
Okay. What do you do for living?
I'm a school teacher, but obviously at the moment I'm on maternity leave.
Okay. And who is supporting you at home?
My partner, and I have, my mom lives down the road as well, so I get help when needed.
Okay, great. Do you have any family history of concern? You want to share it with me?
Can't think of anything.
Okay. Did you ever get pregnant before? Except the last delivery?
No, this is my first baby.
Okay, okay. Thank you for sharing the information with me. I would like to examine you in the presence of chaperone and after your permission. I will check your heart rate, blood pressure, and temperature, plus your height to weight ratio. And I can see that already you were examined and your episiotomy scar was doing well, was okay. So I would like to examine you from down below and I will see if there is any problem with my examination. Is this okay?
Yeah.
Okay. I would like to reassure you that sometimes this problem can happen after delivery, especially if you have a difficult delivery, as you already mentioned, and a big episiotomy. This can happen to any woman who had such circumstances like this. But I would like to reassure you that there is a treatment for your condition, and your treatment will be taken by multidisciplinary care, a multidisciplinary team, including the gynecologist, the physiotherapist, the psychologist, and the sex therapist, and will give you medicine to treat your pain to treat your pain at the time of intercourse or time of speculum examination. How does it sound for you?
Yeah, that's okay, doctor. I'm okay. Whatever you need to do.
Okay, great. So first, I will refer you to the physiotherapist who will teach you about pelvic floor exercise, where you can control and relax your muscles from down below, and we can give you some lubricants if you have some dryness. We can give you some estrogen cream because sometimes with breastfeeding you can have some deficiency of this hormone, which is giving you the same feeling as you have now. I will refer you to the sex therapist. He will speak to you about this problem and also the talking therapy. And we can try with you some dilators from down below. You can use it. It is available on the counter, and it is of different size. You can try to insert it gradually by yourself or by your partner, and with time it will relieve your problem. Am I clear to you?
Yeah, that's fine, doctor. Yeah.
Okay, if sometimes it's not working, so we might give you some anxiolytic to relieve your tension, and sometimes we are giving you, if not working, we can give you some muscle relaxant like nitroglycerin ointment, and in case all this not working, we can give you something called botulinum toxin. We'll inject it from down below in order to just try to resolve your problem. Am I clear to you?
So sorry, doctor. So this medicine or whatever you talk about, like how is that going to resolve the problem? Like what will it do?
It will make you to relax from down below, so we can you can also have sexual activity with your partner, and even sometimes it will help you also to do some special examination like the speculum examination. So you will not feel worried about this that anything is getting to you from down below.
So what's wrong with me, doctor? I mean, why I have this?
Yeah, this is the condition called vaginismus, and this can happen after delivery. As I told you, sometimes because of the difficult labor, sometimes you are feeling you are afraid about touching that area. Sometimes because of the stitches were a little bit big. But with the treatment that I'm already told you, you will be back to normal gradually.
Okay. Right. Okay. Your time is over, but you can add if there is anything else you feel you want to add.
Any more concern?
No, that's all, doctor. Obviously, I just really want to get it sorted because it's causing quite stress to me now.
Yeah, sure. So I'm going to provide you with the patient information leaflet and support group, and I'm going to write back to your GP.
Okay. Are you gonna take my smear today?
We can try, and if you are okay, we can manage. We can put for you some anesthesia cream. Maybe it will numb the area from down below, and it might help us to examine you. But if you are worried and you are not happy to do that, so we can postpone it till the next time, and with the treatment that I already told you.
All right. Okay, doctor.
I forgot to ask about the mental history.
You can ask now.
Okay, in the last 4 weeks, did you feel depressed?
No, doctor, not particularly, but I'm starting to feel a bit, anxious now.
Yeah, okay. So I will also refer you to the specialized team who will help you in your anxiety.
All right. Okay.
Okay. Okay. Any more queries?
No, that's all, doctor. Thank you.
Thank you.
All right. Okay. Okay. So that was good. Very good attempt. A few very important things you forgot to check and ask. But I'm glad you did feel about the mental health screening. So as we said, like for all postnatal women, we must make sure that we do ask that question to do the screening, and particularly the women who have these type of ongoing problems going on. What is going on in here with this girl? Yeah. So now, what can be the possible causes of postnatal dyspareunia? Just like as we discussed, whenever there's a problem, try to make your DD first, the differential diagnosis, think about what possibly can be, and then just exclude them by asking questions. So the possible causes can be number one, yes, if there is some painful scar down there, or if there is any, improperly healed scar, that can be quite a common reason for postnatal dyspareunia. The second can be sometimes it can just be a feeling of fear if they have traumatic delivery and they had stitches particularly repaired and they were painful, then that is another reflex they create, they feel that reminds them about that pain, and that can be a problem. The third could be vaginismus. Fourth could be vulvodynia. Vulvodynia is not something which will happen just as a result of examination. Vulvodynia basically is a pain in particular spot, and that can appear at any time. That's not really just associated with the touch or any examination. So, but you need to keep in mind in case she just says vulval pain, she feels that pain here and there, then you need to throw vulvodynia as well. Otherwise, I wouldn't. In this particular case, maybe she says she can't have the penetration and she's going to do the speculum. Otherwise, she's okay. I wouldn't worry about vulvodynia. And the fourth and very important cause can be psychosexual reason, any abuse in the past, any ongoing domestic issues at the moment. And that is the most important cause basically to explore. If apparently in this woman, she is 33 years old, 3 months by now, episiotomy scar is well healed and all that fine. I mean, it doesn't look like they should be, unless the most strong reasoning when I'm reading this scenario, which will come to my mind, should be number one, either because she has those scarred and painful stitches and stuff, and that's why she's a bit scared, and just the reflex that she has other vaginismus, as a secondary vaginismus because of that, or some previous trauma, which has become again, provoked that feeling and sensation after having those stitches in traumatic delivery. So the way we are, so first you need to do the routine postnatal check. The routine postnatal check is to ask about, so I can see, so how is your baby doing? Are you enjoying the time with your baby? And, is baby well? You can ask about the name of the baby, then ask this next question is to say, so I can see you did have some, they needed to assist your labor with the forceps and you had some stitches down there. How was your healing of those stitches? Did you have any problems in the beginning? Was there any infection in them? Were they like unusually painful to start with, or anything like that? Any problems with your bowels opening? Any problem with your waterworks? Then come to the breastfeeding. Are you breastfeeding the baby? And how is that going on? And then about, have you resumed your sexual activity? And if yes, have you started some contraception? And if not, why not, right? So these are the routine few questions you need to ask. And then you can, the fifth final question is like routinely need to be asked, is like quickly asked about by saying like, obviously, when you're recovering, your body's recovering from the pregnancy state and hormone, and then looking after the baby, obviously it can be quite tiring, sleepless nights and all that. It's not unusual to feel low in mood. And are you particularly feeling, low or depressed in your mood? And then you can come to the problem to say, okay, so I can see your doctor has sent to you because you're going to do this speculum, are you going to do the smear? So would you please like to tell me more about this? What exactly is the problem you're having? So let her describe now about the pain. So hopefully she will give you a lot of information in that answer anyway. If it's a constant pain or not, and it's on the examination. If not, then you need to ask, okay, so you found that examination painful. So tell me, did you feel pain? Which area particularly do you feel in pain in there? Is that just on your entrance or your vulval area? Or where particularly? Is there any particular spot which you feel is painful? And then the next question you need to ask is like, and if she obviously then see what she says. If it's only about the examination and the the penetration, then you need to ask, so what about your sexual activity? Did you find having sex painful? And then if she says yes, it's important to then understand the level of penetration. So you can say, okay, so you can say like, just to help me to understand what exactly is going on, I will need to ask you more questions about your sexual intimacy and more details about that, if that's okay with you. And then just ask about saying, okay, so so when you have the sex, do you have any penetration at all, or you cannot tolerate the penetration at all? So that just help you to then decide between the vaginismus, yeah. And then the next question I will ask her will be, I will say like, do you feel the pain basically? You feel like, as if your vagina get tightly shut or closed, your muscles get contracted in that time. So can you differentiate that difference between, is it painful or is this is what is happening? So establish that first. So if it comes to only during the examination or during the, the sexual intercourse, then you need to ask the question, did you have any sort of this type of problem before delivery, during your pregnancy, or even before at any stage? Yeah, so establish that one. If she had some vaginismus or something going on previously, she might bring that up. So take that into consideration. Then my next question will be now to ask her actually psychosexual history. And then I'm just going to simply say, so sometimes the women who have any, sexual abuse or any domestic abuse in their current relationships in life, or even in the past, and even in their childhood, they can actually, that experience and then pain can get provoked as well after the delivery because of having those intimate examinations, and particularly when they have the tear or any stitches down there, that can actually provoke that pain as well. And that may be one of the possible reasons. So have you experienced any such issues in the past or currently? And if she's not able to have the sex, then we need to make sure here what's going on with how the partner is coping with that. Is the partner supportive particularly, or he gets annoyed? How the partner is supporting in this all? Do you feel yourself happy and safe with your partner? So if she, then you need to take what she says. If she discloses here that there is actually something in the past which has already, yes, this is provoked, then obviously we will go on that line. Then we need to get the information about what was happened, what was done. Has she discussed that before with anybody? Has she disclosed it to anybody? If it was a past one, would you like to disclose, and even present one, would you like to disclose it? Would you like it to be something done about it? If it was done as a childhood, like below the age of, as a child, sexual abuse, then that needs to be reported to the police, right? In that case, we will need to first ask her, check her, has she reported? If not, then we will encourage her. How you feel about then if we, discuss with our trust safeguarding team and get the police involved as well, because that particular person, perpetrator who did that all to you, he might have still be continuing to do this with other children. So there may be a lot of children at risk being abused by that person. So obviously it's not easy decision. Most of the time these women just want to run away from the situation. They will just say, no, I don't want to do anything. I just, I don't want to, it will be stressful, anxiety, I don't want to initiate that chapter again. Then we need to say to her, okay, so what we can do, we can actually approach this matter in an anonymous way. So would you please like to give us some details on about that person, who that person was? And the way I can reassure you, I will discuss with our safeguarding team, the way they will actually approach that person and sort it out will be completely anonymous, and your ID won't be disclosed at any stage, and your safety and anything won't be compromised. It will be absolutely confidential and private. But it is important. If she's happy, if she goes ahead with this, says, okay, you can do that, then it's fine. If not, then we will say, I'm afraid it's very important. And it's not like, there could be other children at risk. I will need to discuss this with my safeguarding team and with my consultant as well. And then something needs to be done about it, because it's a wider risk of abuse to the children out there. And mostly after this, they usually agree to disclose. So that's about if they disclose anything like that. And even if it's a current one, with a relationship, then obviously we won't go and say, I need to discuss unless you give us the consent. So if there is any domestic abuse or any pressure, anything going on, then we can offer her, how you feel about doing something about it. And then just like as we do for domestic violence, offer her support, encourage her to do that. This shouldn't happen to, shouldn't continue. It's going to affect your health, your long-term mental health, your baby's health. And this, relationship is not healthy. Encourage her. If she's happy to do something, then we will say, okay, I will discuss with my safeguarding team, and then we will make refer to the Marak. If she's not willing, then we will say, okay, so I leave you with some contact details of these domestic violence support services. They're specially trained people. Keep this number. When you feel ready, you can give them a ring. And the way they will approach this method until this will be in a very sensitive and anonymous manner. They are aware that actually when any woman discloses these matters, and when we start doing something about it, then these women are actually at quite high risk of being harmed. So they are well trained to make sure that we guard your safety first. So reassurance again there. And then in that case, if the current one, obviously we can't go against the consent unless she discloses something like that, there are other children, there is a clear, beating all that going on, and there is a child at home, then obviously the child safety comes up. Then in that case, we will need to say to her that I'm afraid, because you have a little child at home as well, there's a safety of the child is at risk as well. So I'm going to discuss with this, and then we may need to take some appropriate action. So that's about if that goes in that way. So let's assume in this particular scenario, I don't think it went that way in the exam. So then we can say, so if it clearly goes towards vaginismus, if she can differentiate and say, yes, actually, yeah, that's what I feel, and that's not in my control. But then XYZ, my partner feel I'm just doing that by intention and blah, blah. Then you can say, no, I can see that. And this is a condition, we call it vaginismus, and you're absolutely right. It's not something you can control. It's a kind of, whenever those muscles, they can actually go into strong contraction and close tightly. However, do not worry about that. We can deal with it, and we can resolve it as well. And it's not only you, it's not uncommon. Some women can have their problem. And if that's not even the case, it just overall, then you can simply say, okay, so what happens basically, it's not uncommon to start feeling difficulty affirming sex or having those examination, because when you have obviously the labor and you have stitches and those traumatic experience, you have pain down there for a few days, obviously what happens, your genital area and that area kind of becomes sensitive to touch and the fear of pain. So when you try to have resume sexual activity or speculum examination, your basically your body just kind of react the same way as when it was tender and in pain. So we kind of really need to desensitize and train the genital area just to retrain that it's okay being touched in the area. And then obviously we can talk about, depending upon what she has told us. So then we can say, okay, so if it's vaginismus, then we will talk about again, the first thing will be sport, counseling, desensitization. And the desensitization will be, we will advise her to just try with her own fingers, being like starting with the one finger, slowly touch that area, then start the penetration, and then feel, because you have the control, you know you have the control, so you will be able to do that slowly, then increase it to 2 fingers and keep it there, try to take it deeper. And once she's able to do that, then she can involve the partner as well if he likes to, and that will kind of give them some sexual pleasure and foreplay as well. And then hopefully slowly and gently then working between both of them, and we can actually offer the support and counseling for the partner as well. And then you will be able to resume your normal sexual activity. If not, then we do have those dilators which can be used as well, slowly putting them in and leaving them there, increasing the time and the depth of that penetration. And that will apply basically to vaginismus as well, to both, to the vaginismus as well as to the this provoked trauma experience. And then yes, we can encourage her to have the perineal massage. So we can say, like, you can just use some oil to give a little massage around that area, and the perineum, that will increase the circulation, sensation, and that feeling of your normal sensation to return back, and some physio therapy and exercises. And then accordingly give information. Now for this woman, I will encourage her to have the examination. So what I will say, I understand your GP could not examine you, but if you feel it's okay and you will be in a total control of your examination, and you can tell me to stop at any stage if you wouldn't like that or find it painful. But if that's okay with you in the presence of chaperone, I would like to examine you down there, and then we can try with the small speculum to see, that will help me to understand what exactly is causing you that, the problem. And then we can address it accordingly. You can always ask me to stop. We don't have to hurry to take the smear today. So just ask her about the previous smears. Has she been up to date with the previous smears, and have they been normal? So as long as they are, we'll say we have no hurry about taking the smear. Let's sort this out first, and when it will be comfortable for you to tolerate the exam, then we will take the smear. Right, that's it. Now, obviously, it might have been a fairly like 1 hour long discussion because I have covered all the possible causes. If that's the cause, how are you going to? But obviously, you need to listen this and then make your own notes. Like, if that's the cause, how I'm going to speak these points. There will be a lot which obviously you won't have to go into detail. Quick questions.
Ma'am, what is the difference between vulvodynia and vaginismus?
Okay, so the vaginismus is involuntary spasm and contraction of the vaginal muscles, and that happens usually just on the touch, like during sexual activity or during the speculum examination. That simply is the spasm of the vaginal muscles. Vulvodynia is a provoked pain. They usually give very clear history. The way they will start with as a vulval pain. There will be a specific area they will say. They are able to touch actually and tell. And when we examine, we do the mapping of the area. So we start, touching from the introitus, and we go along the vulval introitus whole area in a clock or anti-clockwise manner, whatever. And then we ask the women to tell us particularly which area and where it is tender. So vulvodynia is basically neurological reason, and we give them amitriptyline as a treatment. Vaginismus is different thing. I've explained you already. It's just the involuntary contraction of the muscles, and you need to basically start them with the desensitization technique. you know, from the simple desensitization up to the use of dilators.
And Dr. Abba was telling about that nitroglycerin patch, and this is useful or no use in this vaginismus, doctor?
In vaginismus, nitroglycerin patches will not have any particular role, because it's more to do with the for the temporary thing. Say if we really are desperate to take some examination and it was abnormal smear and we need to take that smear, then yes, we could use that to do the examination, but that can't be a long-term thing, you know, because she can't use that every time for sexual activity or things like that. So it's more of a retraining of our muscles and desensitizing the muscles. So I wouldn't particularly go for that. Okay,
Dr. Safia, this is also applying to, sorry, this is also applying to the botulinum toxin, even not for the temporary relief?
No. That one is like last resort. So first we will do this all, examination, desensitization, dilators, everything, consult. And if still, we are still stuck and nothing is moving, then that's going to be botulinum toxin stuff.
Yeah, this is by order.
Not initially, no.
Yeah,
and
exactly.
usually we don't need it. I mean, I do vulval clinic. I have never reached to that stage.
Okay, thank you.
Dr. Safia, what about, I heard about removing the scar, it's an operation.
Okay, so if it is, you want to have me today. Okay, so if it is because of the scar, if it says, okay, so there was something written, I mean, I have deleted now from there, but it was actually, somebody told me in the exam as well, that the GP feels is atrophic vaginitis. Let me explain that as well first. Now, for a young girl of 33 years old who just have a delivery, that means our hormones, everything is working all right. Lactational amenorrhea is not that type of menopausal, like it's causing ovarian suppression to that extent that this woman should start having atrophic changes in the vulva. So if it says like she has the pain down there, so ask about the rash and soreness, pain down there. If she is, then you need to examine her for lichen sclerosis. And then yes, the treatment will be, but you need to then mention if there is particularly anything. So thrush, if she's give the history of rash and soreness down there, then you know, overall pain and stuff, then you need to consider thrush like candidiasis and the lichen sclerosis. I wouldn't assume any woman who just is delivered to have atrophic because of the estrogen lack. I'm talking about the estrogen pesticides and stuff. So start with the emollient, start with the steroid creams, or with the candidiasis. So if the scar is tender and painful and hypertrophic scar, then obviously we will explain that accordingly, that it's in some women, when the scar is repaired, their body actually can, give over response to the healing process. And as a result, there is, the scar become quite thickened, and that can be painful as well because of some inflammation in that. So in that woman, then yes, the start will be to perineal massage, physio exercises, and then some steroid cream to start. So some strong steroid like clobetasol. And then if there is some visible inflammation, then we will say, if she's not breastfeeding, give her ibuprofen. If she is, then simple paracetamol. And then depending upon, you will then offer her to examine and do these things. Now, if it's just a hypertrophic scar, then we will start with clobetasol cream. The steroids will help it. And if not, then the next one is intradermal injection of the steroids. Canacort injection is given, which we can give as a gynecologist, or we can refer to dermatology. Or then the fourth and the last option will be to discuss about the repair again. But again, in that case, we need to tell that if your body has actually is hyper responsive to the healing process, so there is a risk that if we do the repair again, then that they might just heal with the overgrowth of the scar again. So that will be the scar. And I really want to close now because last one kind of took quite long. Is there anybody else running left from your?
I think Deepti has joined now. I saw Deepti's name.
Who
Deepti's
joined?
here. Deepti, earlier she was not there when we called her name. Deepti.
Go, Deepti, go wherever you are. Go there again, please. Okay, all right, okay. If she's here, then I can take next
Deepti?
station.
Yes. I was I was just driving, so yeah.
Why didn't you get stuck in the traffic?
Yeah.
Okay. Let's see then what we give you now then.
This is for me.
It will be for you, Dipti, but I'm still trying to find out the scenario for you. Give me a second.
Yeah, no worries.
Okay, there you go then.
Sustained third degree perineal tear during labor. This is actually not Leah, ma'am.
Hello, Dipti. Are you happy?
Yes, ma'am.
Yeah.
Yes, I can start. Yeah. Hello, I'm Dr. Dipti here, one of the doctor in the postnatal ward today. May I confirm your name and age, please?
Yes, doctor. My name is Samantha Rhodes, and I'm 28 years old.
Good, Smith Road. How are you, my dear?
I'm not too good, doctor. Because
What's the
of the
problem?
yeah. I mean, I had this tear, which I'm told that it went back right up to my back passage, and they stitched it, but I'm still having leakage of stool from there, and I'm really worried. Yeah.
Did you take some painkiller tablets to reduce the pain?
Yeah, I'm taking them. I mean, the midwife gave me, I have been taking those. Yeah, I've been taking all medicines they have asked me to take.
Yeah. Don't worry, Smith. With the physiotherapy, with the exercise and all, it will be controlled. Don't worry. How is your breastfeeding and did you pass the urine? How is the water works? Is okay?
Yeah, that's okay. I have no problems with in passing urine, but I have no control on my stool.
I see. And can you tell me more detail about your delivery?
Yeah, so I was not able to push the baby down, or the baby wasn't coming down, whatever. So they needed to give a little help with the forceps to deliver the baby. And then, there was some tear down there. So they took me to Fetal to have a good look on that tear and to stitch it. And then they told me that tear was actually extended to my back passage. They have stitched it.
Oh, I see. And how is your baby? Baby is good. What's his name?
Yeah, baby is doing good. Yeah, so I'm calling my baby Amelia.
That's lovely. And do you have any other problem? You feel low and anxiety and all after that incident?
Well, I'm not feeling low, but obviously I'm quite anxious and worried about because it's pretty embarrassing, the situation I am. And I mean, I'm just so worried. I smell bad, and and I'm worried like whether it will get corrected or not, and do I have to live with it now or what?
Don't worry. And what about your? Are you drinking enough quantity of water and liquids? Are you mobile? Are you mobile? Hello.
Sorry, say again, doctor. I couldn't hear you.
Are you mobile? Are you walking around? Because in
Yeah, I have been up and about. Yeah, I have. Yeah.
yeah, because sometimes after delivery there are chances of blood clots in the legs and lungs. So it's always better to walk around and to hydrate yourself properly. Okay.
I have been used.
Yes, that's lovely. So don't worry, Smith. Actually, this is we call as perineal. This is a deep tear, that is a deep cut in extending to the back passage. Usually, it happens when the baby is delivered by some kind of forceps or ventouse, and when there is a tough and when there is a big size baby. Can you tell me how much was the birth weight of the baby?
Yes, my baby was about 7 pounds.
Okay. And was there any other issues during pregnancy, like high blood pressure, diabetes, anything?
No, I didn't have any issues.
Any other medical health issues?
No,
No.
it was pretty straightforward pregnancy, doctor.
Okay. And do you have any kind of allergy to any medicines or latex or any food stuff? Food substance?
No.
Okay. Any surgery, especially in your tummy and below down, other than this?
No, I never had any operations. No.
Okay. So tell me, what is your main concerns? You're just worrying about the next pregnancy, about this scar, or something else?
Well, I'm worried about everything, doctor. The first, obviously, the immediate issue is it gonna, why I'm still leaking? I mean, if they have stitched it, have they not stitched it properly? And in first place, why this happened? I mean, was the doctor not actually well trained, and she just caused me this tear?
Sometimes it takes some time, so it will be, and I can just speak to my consultant and with the bowel doctor also, and there is a special colo surgeon doctors are there. So we will just discuss your case with them, and they will check you into detail what is going on, and in case if need is there, then we will do the specialized ultrasound in that area, and they will check whether there is a deficit or no. But most of the times 60 to 80 out of 100 women in your conditions usually heals well at the end of 1 year, and some ladies, some women can take
So
little
I
longer.
will have, sorry, doctor, that's really frightening. So I will have to live with this for 1 year.
No, it can come. It gradually it should be corrected, and maybe we will put you on some exercises. Our physiotherapist can help you to do some exercise, and it will increase the tone of your back passage muscles and all. It will definitely help you, and our bowel surgeons, colo surgeons can also help you. Okay, so don't worry about that.
Okay.
And did you take sorry?
Yeah. Yes. Is that going to, is that going to affect my fertility, or is going to cause any problems with my next pregnancy?
Actually, during next pregnancy, the chances are very less actually. So don't. Most of the times it helps by the end of 1 year, and we will just put you on the special scan on the back passage, and if we found that some kind of deficit is there, then in that case my consultant can advise you to go ahead with the planned cesarean section. And if you are okay, if you are improving and there is no deficit, then definitely you can go for vaginal delivery.
Right. Okay. And what if it didn't? If it didn't, improved?
Most of the times it should be improved. Our group of specialist doctors team will definitely help you out. What to speak,
Okay.
ma'am?
So that's quite worrying, doctor. Then I'm really worried, to be honest. I'm not really satisfied.
We can I will just discuss this issue with my consultant. Ma'am, it's over now. I don't know anything.
All right then. Okay, that's fine then. Okay.
Oh my
So,
God. What to speak?
don't worry. You just tracked you down as soon as you came home, so it's all right. Okay. So third and fourth digit here. Again, very favorite question for the examiners. In every exam, there must be a question on third or fourth digit here. And then it depends on the role players as well. Some decide to be just okay, sensible, and take the advice, and some try to harass you, being angry. Why this happened to me? It shouldn't have happened, and other stuff. So how we talk about this? Obviously, yes, it is. It is quite basically stressful situation for the patients, and when we're talking about them to telling it can take an average, up to 3 months for healing. And after that, yes, it will improve. Most of the women will improve in 1 year time. So thinking about living with using a incontinence pad with fecal incontinence, even for a day, can be a horrendous thing to do, what we are talking about. So that should help us to understand why these women feel frustrated, why they feel angry, and then again, mental health issues in sport and counseling is really important thing. Incontinence nurse role, all that sport. So it's a lot of empathy we need to acknowledge here. So these women are, there is another scenario which usually appears in the exam, 4th degree perineal tear, and she comes at 6 weeks postnatal check, and she has, again, she's still fecal incontinence. So just a routine thing to start with, to just open up first after introduction. Usually you are called by the midwife in these cases, or even if not, you can say, so I can see you here, or, you have some concerns about the tear down you have and the stitches. So do you want to tell me what are your concerns? You want to tell me, what you want to discuss? So just invite them, open question, let them know, let them tell you. Whenever you feel in any scenario that there are some concerns, particularly the scenario says you're called by the midwife to come and talk about that the woman is worried or woman is angry about anything, or anything like that. In that case, the thing to do is to introduce yourself and then just, I have been asked to come and speak to you because you want to, speak about this or what. So please tell me, how can I help? Or tell me what are your concerns? So just open question, let them let out whatever. If they're worries, let them express it. If they're angry, let them express it. So right, okay. So this woman then tell me, never make a mistake to for these scenarios to ask them, who are you? Okay, they can't be sometimes very mad. So then you will ask them whatever they tell you. Okay, so this woman says, okay, I have this, and I have that tear back, and I'm still incontinent, or I'm leaking, and that's really embarrassing, and that's really painful. And then you can say, the answer is always first acknowledge, and that helps them to calm down a lot. So just say, I can see it must be very distressing and difficult for you. And then you can say, okay, so let me ask you a few questions to help understand what type of tear you have, and then will help me also to decide what we can do from here. And then you can ask about, so did you have any problems in this pregnancy? How was your labor? Was it a long labor? If that information is not given, if it's given, then it's okay. You can just say, so I can see your labor was quite long and you had this instrumental delivery or whatever, and then there's stitches. So in this particular scenario, the exam, she said, like, I had this delivery done, and then there was a tear, so they took me to the theater to examine and stitch it, and but I'm still leaking. Then I will say, okay, so what happens? Let me, to help you to understand what exactly is happening, let me just explain you that what is this tear and what happens in this tear. So then you can say, no, obviously this exam is online, so all you need to do will be just to make your, tell the patient with your hand. I'm just going to put camera on. Ignore me, I'm not in makeup or lipstick, but anyway, I need to show you how you could do. Can you see me?
Yes, yes, ma'am. We can see
Because
you.
I can't see myself. Okay. Right then. So, right. So what you can do,
Was
where am
there
I going?
any Jamboard type of software we will use during the exam? Jamboard.
We'll talk about that, what software they use afterwards. Right, so you just simply can do this type of thing to show basically the introitus, yeah? So you will say, so, you're opening of the vagina, and then you got the back passage just below here, yeah? So just give that picture. And what happens at the time of delivery, there's a stretching of this perineum, we call it. And because of that stretching, sometime there can be a tear, which can extend right up to the back passage. And then you continue to explain to say, so the lower end of the back passage is kept tightly closed with the help of a band-like structure, rubber band-like structure. We call it anal sphincter. So in this type of tear, which we call it a third-degree tear, means that that tear actually has extended from your, the vaginal area through the space between the back passage and this, and right up to the external part of your the sphincter, the rubber band. So when that happens, obviously, that muscle is broken. And the way we stitch, we actually try to then put all these, muscles and try to repair this band. However, it can take time. It takes time before it is completely healed. And then this muscle and this band can actually regain its full strength and tone back. And obviously, till then, this opening can be a little bit loose, and as a result, there can be some leakage of the stool. However, as the healing will progress, you will feel that this leakage will significantly increase, and it depends on the healing response of the body of the patient as well. Some people, they can heal very quickly, and they will not have any problems, like even within a week or so. But on average, after three months with this particular type of tear, we expect that most of the women will have complete healing, and they will not have any problem. Some fraction of women may continue to have a little bit of, lose, a little bit of leakage of the stool, and particularly of the flatus. But let me reassure you that 80% of the women will be completely without any symptoms at the end of 1 year. So try to do this 80% in this way, rather than saying 80% will not have, because that just give a sinking of heart. So do I have to live with it for 1 year? So reassure her. So then we need to say, so it's very important that we do take a proper care to facilitate this healing. So we need to make sure that this area is not infected. So it's important to keep it clean. Now I will check on your, the drug sheet. I'm pretty sure you would have been prescribed with some antibiotics and the regular pain relief. So then check with her, have you been taking them regularly, the pain relief, and is that helping? And then you can say at the end of this consultation, I will just have a quick look down there as well, just to make sure that the stitches are healing nicely and there is no signs of infection or inflammation. And then you need to say, like, okay, so to facilitate this healing as well, it's very important that the blood flow and the circulation in that area remains good as well. So we will make your appointment with our physiotherapy as well. They will help you just to do exercise of these particular muscles so that the healing and the circulation improves and the tone and strength of these muscles improve. And also, it's important that you do some perineal massage, we call it. So you can use, any baby oil or any oil, and then just slowly, with the help of finger, when you feel your pain free, just do that massage around that, around your back passage and the area between your, the opening of the vagina and the back passage. We call it perineal area. So just do that. That will increase the circulation. That will also heal the process of healing. So that's one. And obviously you said, but then yes, I'm afraid you will need to continue to use the incontinence pad. And then if you're really worried, I can make an appointment with the with incontinence nurse as well, so that you can just ring or get help if you want to. And then we will make an appointment at 6 weeks when you will come back. We will review that improvement in your symptoms, and I can quickly examine you as well at that stage. And if we felt that you still are having significant incontinence and leakage, an examination, if I feel that there might have been some defects still there, in that case, we may start our intervention earlier. So we don't necessarily have to wait for 3 months or 1 year. So we'll do that assessment at that stage when we come to that stage. And if we feel that there is a significant leakage and all that, and it needs to be assessed, then we will make your appointment with our bowel surgeons. We call them colorectal surgeons. They can assess. They will assess the tone of that muscle as well. There is a special scan test for that. We call it, what we call it. Come on, girls. What we call for the anal tone scan?
Endoanal
ultrasound. Yes.
Anal manometry.
Transrectal and endoanal.
No,
Endoanal ultrasound.
Yes, that's
It's actually who passes a probe through the back passage to see that.
It's fine. Yeah. So just say like we will be doing. They may want to do that scan to see the tone, and then if they feel that some intervention or repair is required, that will be planned for you. However, we will discuss that with you and inform you everything. And after that, and reassurance stuff, we obviously need to tell her, another thing we need to check is to make sure she's taking fibrogel or lactulose, and then inform as well that just take them for 5 days and then stop and see. It's important you do not get constipated. So, have a plenty of fiber intake in the form of fruits and vegetables, and plenty of water intake. And then and then you need to again acknowledge to say, so I obviously I understand this can be quite difficult and stressful situation for you to go through this, because when you have a little baby to look after as well, then pregnancy hormones recovering back and all that stress and this additional stress, it may not be unusual to feel anxious, worried, low in mood, depressed. So if you feel that you're really struggling with your mood and all that, then please let us know. We do have, again, the team and help available to help you to help your management of your mood. Sometimes you may require some counseling or even some medication. So please do not ignore that. Because leaving it or ignoring or delaying it can actually result into worsening of symptoms, and then sometimes it becomes really difficult to control the medication. In the beginning or at this stage, you can talk about the baby. Try to check about the bonding with the baby, how you feel about your bonding. Are you enjoying time with your baby? Are you breastfeeding? Are you doing? Discuss about the contraception. To say it's very important that you do have a gap between your next pregnancy. It's also important for the proper and complete healing of this repair as well. So I will discuss, and then we will arrange a safe and effective contraceptive method for you before you go home. And if she's going home, kind of says she's ready for discharge, then you can say I will discuss at the end, and then we will start you on your method as well. Yeah, and then just offer the contact number to say if you have any problems. Obviously your midwife will be visiting you when you go home. So if you have any problems, please just let her know or give us a ring.
Ma'am, in such situation we should not ask her name and age. Because already, because here in the agenda, name is not mentioned here.
No, I
Hello?
didn't make that particular agenda basically. This was in the last exam. So when the candidate told me, I just put that information there. The name will be there. Obviously, you more blindly go in any room. You will have a look on the notes first. So you will know the name. And if the name is given, you should always go in and call by the name. And then
Okay,
say,
okay.
can I confirm your name and date of birth?
And in this scenario, ma'am, if she has third or fourth degree tear and or after assisted delivery, so she's also be put on blood thinning agents. Do we also have to mention in this scenario?
No, if she's mobile up and about, then we don't need to, unless there is a routine, whatever is required for VTE risk assessment, if she's not particularly because of third or fourth degree tear. If she has additional risk factors, then you can. But you can ask her as a part of your routine that they check, have you been up and about? She asked me, has you been mobile? So that will, that would have been prescribed. You can look at.
No need to specifically mention about hyperina, ma'am, in this case.
No, the tear itself is not an indication for that unless there are additional, you do your risk assessment, that for a point score of the VTE to see what she needs. But for her, if her BMI is normal, you can ask that. And if BMI is normal, she's up and about, keeping her hydrated, then all you need to know is just to encourage her to increase, keep herself well hydrated and mobile. And yes.
And today is third postnatal day. So should I mention about incident reporting? I was little confused about that part.
Yes. Thank you for reminding. Yes, incident reporting is always done in any complication, irrespective.
Yeah, so I should have mentioned that whatever is there, we will make an incidents report
Absolutely.
and how to explain patient about duty of candor. Like I'm always reading a duty of candor. So what we speak, it is duty of candor, or we have to specifically speak out that word to patient.
So you first tell me, I will explain you, but let's relate to this scenario. Is there any duty of candor in this scenario?
Honestly speaking, no, just the incidents reporting.
So the duty of candor is when there has been some clear negligence or the mistake made, then we have to be honest and accept that one. Third degree tear is one of the expected complications, not only the instrumental delivery, even during the vaginal birth. But we always do the incidence reporting for everything. So, when she says why that happened or why that happened to me, then we can say that, it's not unusual for these tears to happen. However, because during the process of birth, when the baby is descending down and coming, it distends and stretches out your muscles. If she asked that answer particularly, then if you have to answer. And when the baby is delivering, because of that stretch, there can be some tear. And we are aware of that. So the midwives and the doctors who are delivering, they try to support these muscles area, we call it perineum, to prevent from these tears from happening. But, we know they can happen. It's one of the complications. However, whenever these complications happen, we always report the incident. We do the incidence reporting, we call it, so we can do a detailed analysis to find out if there was anything different we could have done to prevent it from happening. All right. So the difference between is when there is no mistake, we feel it's one of the complications. Then the word we use is we analyze to find out if there was anything different we could have done.
Okay.
If there is a clear error, we have done something like we perforated that uterus with the trocar, then that is the duty of candor. Then we need to tell to her that to explain with debriefing. I'm really sorry and I apologize that this complication happened, this. And this happened because of this error that we missed to put the catheter into your bladder, which we usually do before this surgery, that empties the bladder and keep it away from the area we are operating. But we unfortunately, for some reason, we missed to put that catheter in. And as a result, obviously, your bladder was full and it was in the area, and that got injured, during that process. So we have, discussed between the team as well why that happened. We have a very robust system in place where we do all the checklist and we make sure that all these steps are done before we actually start the surgery. So we have reported this as the incidence. We're going to do a detailed analysis into this incidence to find out what went wrong. Why we, so here we are saying what went wrong, why we missed to put that catheter in. All right.
And when to utter datics also, ma'am, many times it's commonly we are hearing. So when to bring that into our chapter?
Datics is risk incidence form. That is called datics. Datics is basically just that system on the online system, the way we report that incidence, right? You just say incidence report. We will report this as an incidence.
Dr. Sophia, discharge letter. So how many copies are doing? One for the GP and one in the hospital and one for the patient? And shall we mention that for follow-up?
Sorry, discharge letter what?
How many copies? One for the patient, one for the in the hospital, and one will be for the GP for follow-up. Shall we mention about that? Means we'll write the follow-up plan.
That's the discharge letter.
Yes, yes. The written form.
Written form. You mean this? You're saying, sorry, I'm not getting you. There is interruption as well in the voice. So you're saying, correct me if I'm wrong, that when we do the discharge letter, how many copies we do, and is there one for the patient, GP, and the record? Is that what your question is?
Yeah, this is part of my question. Second question is, shall we mention it to the patient if the patient simulated tasks that I will write to the GP and the plan for this one follow-up plan?
So yes, when we discharge them, so we'll be basically doing how we do the discharge letter in our not the session after in clinical governance one. But when we do the discharge letter, yes, when we are discharging them, then we tell them, you know, that community care about that one, like you need to do this. I will make, and if there is anything we want from the GP to be done, then we just inform the patient as well. Say, for example, this was a lady with preeclampsia, which stabilized, did everything fine. Now we are discharging her home. Then when we will do the discharge letter, I will show you, there will be some plan and instructions for the GP or the follow-up by the GP or for us. So follow-up, there is something called follow-up in which you write down like 6 weeks postnatal clinic. And then instructions for the GP will be, so for the GP, number one will be, we will be asking for the GP to monitor the blood pressure and then taper off or adjust the medication accordingly. So there will be, and if there are any blood tests which are still awaited, if we have done as the results are not available yet, we will write on that for number two for the GP as well. Please follow and chase up the results of these investigations. Number three, if there is anything else, you know, if we want GP, actually, she's not clear about the contraception, and there's a number three, then we will say, you know, please discuss and start appropriate contraception, this type of thing. So that will be written over there. But in this woman, when she has, so this particular woman with the 3rd-degree perineal tear, because it's day 3, on her discharge letter, we will be, basically we will prescribe. So again, when we will come to the discharge letter, I will show you that how that looks like. We will be prescribing her remaining antibiotics with the doses and how many days left behind, 2 more days or whatever. Then we will prescribe her Fibogel and laxative and the pain relief as well. If there is something we're writing, say again, say this woman had hypertension as well. At this stage, say for example, we are going to discharge our labetalol, whatever, 250 milligram twice daily. We will prescribe that as well. But then we will make a write down in the GP plan to check. So that there will be, say for example, daily check for a blood pressure by the community midwife for first 1 week, and then review by the GP maybe after 7 days. So we can give some plan here. So what happens to these copies now? The copies are, we will print 1 copy. So everything is in the computer. We have just filled that on there on the computer. 1 copy obviously is going to stay with the notes that will stay there. 1 copy we will print out and give to the patient to take with her. The other copy, again, just through our internal communication system, system 1 communication we call it, it's different use that we just send that to GP directly. All right.
Dr. Sophia, this patient, we can discharge her if she is still complaining of leak of stool?
Yes, because we do know it's a normal, so unless there is any bleeding and infection signs and anything else, we do know she can have this for a week or even up to 2-3 weeks. So we will discharge with the instructions that if you feel it become more painful and it's not improving even after a couple of weeks time, and it's rather getting worse, or you have any pain or any foul smell discharge down there, then you need to see your GP immediately first place, or inform your midwife, and then we'll arrange your appointment.
Okay, thank you.
Okay
Dr.
then.
Sophia, one question. Sorry.
Yes, Hala.
Regarding this patient now with fecal incontinence, so what advice I should give, because lactulose and high fiber diet is going to increase her symptoms.
No, we're just going
So
to
how
stop
can I
that.
help?
After 5 days, we're going to stop that. Then we're going to give her advice. It's important you do not get constipated. So take plenty of water, fibers, and fruits and vegetables in your food.
Shall I give antidiarrheal for a while?
No, we don't want her to get constipated. Nothing.
But so I will leave her with her incontinence, no problem. But just incontinent pad.
Yes, because incontinence is not because of some abnormal bowel movements. The incontinence is mainly because of obviously the defect in the tone of anal sphincter. So the initial few days, the purpose of giving fibogel and lactulose is basically to keep her stools soft and bowels regular, because we don't want her to be constipated, which can be highly likely because she's painful in that area. So she may not be able to empty her bowels completely. That will result into constipation, hard stool, further stretch in that area, and that will impair the healing. So we can do that for a few days, and after that we can, leave them to just on the normal way to do. So we don't basically do anything either, unless again they complain that they've been actually constipated. Then we just give them fibogel. Fibogel doesn't cause incontinence and liquid stools. Fibogel just increases the normal bowel movement. That is just a fiber. So then after that we can continue fibogel. Fibogel can be continued. We can stop lactulose, and it's not unusual. It's expected. Some patients will be incontinent after 3-4 days, and even up to 3-4 weeks. So unless, as I said, there are signs of infections or anything else, we don't need to worry with these all sport, and giving that the reassurance they can contact us. We will just send them home. Norania is asking, can we then, with the incontinence at 6 weeks, do I refer to bowel surgeons then? At 6 weeks, Rania, if somebody is coming with still significant symptoms, then we said we may consider then. So we reassure them, we will examine you and see. And if they are, then obviously you're going to discuss with your consultant. And if it's significant leakage, and other than, yes, we will be making early referral for the bowel surgeons. We don't necessarily need to keep sitting for 3 months.
Ma'am, but here already she's
send the questions in the group, please. Okay, ask whoever was talking.
Yeah, ma'am, already she's having fecal incontinence. Still, I have to advise her high fiber diet. I was little confused about that. And lactulose also. There will be more fecal incontinence.
No, I want to cry now, Dipti, please. Stop doing this. Please, girls, fibogel does not cause incontinence, right? It does not make the stools liquid. So fibogel has no role to cause the incontinence. Incontinence, I've just explained this answer. It's because she has a defect. We can consider to stop lactulose if she has increased frequency. She says, yes, she actually is having, there's a difference. What will lactulose do? Fibogel, forget. Fibogel doesn't cause the liquid stool or incontinence, so we're not worried about the fibogel. Lactulose. What lactulose can cause? What can do lactulose? Lactulose make the stools liquid, and that increases the stimulates the bowel movement. So if she says, like, she's having like quite strong and frequent bowel movements itself, then yes, we might say, okay, stop the lactulose. But this woman, yes, you can consider to stop lactulose, but keep her on fibogel because she's in pain. She will be holding her bowel movements to empty her, particularly because it will be painful if she's passing any hard stools. And fibogel, I mean, I'm not joking. I'm just literally telling you, you all can try actually for a couple of packs, a couple of days. Fibogel doesn't cause any liquid stools or something, just normal soft stools, okay? It's just the fiber, like taking, if somebody take like 4 oranges in a day, or take 1 pack of fiber gel. That's the same. All right. So don't confuse yourself.
Thank you so much, ma'am.
And ma'am, this is not a question. Actually, next Thursday is our booking opening.
Yeah.
So just wanted to tell you.
Yeah, I know. So right, okay. So for the booking, obviously, it's gonna be busy. You all have that experience before as well. Unfortunately, there will be still some people who will not be able to book it. So please don't get disappointed if that happens. Just a couple of the tips. Obviously, take your proper time off for that time to sit on your laptop. So you have the link open in front of you. Just as a backup, obviously, you can ask some other family members to have the link open on another laptop as well. But obviously, don't open too many of gadgets and devices that your internet breaks. So make sure everybody else is off from the internet at that stage. Use proper debit card, your main bank card, direct, we call them debit card. And use that for of your proper, whatever the well-known banks are, instead of credit cards. Sometimes the transactions with the credit card, they take a bit longer because they go through certain clearance filters. So my advice will be to use your debit cards, your proper bank card. Okay.
Thank you, Dr. Safia. Thank you.
Thank you, ma'am. Good night.
All right. Thank you
so much, ma'am. Thank you so much.
Dr. Jabin?
Yeah.
So once the course finishes, can I request you to give us the slides for these PowerPoint? I think I sent you a message regarding that as well. I mean, after listening to all the recordings, once we are, quick revising, and then yeah, that would be just like, flash revision for ourselves once we have listened to all the recordings.
So the slides for the, because I have slides, there are only few where I have actually the role play instructions and stuff like that. Otherwise, they are just the recall questions. So you mean recall questions?
Yeah, I mean, I'm asking for myself because, once I have listened to all the sessions on recordings, then just towards the end, towards the last 10 to 15 days, when I'm going through quickly, I've done this session, and then which station is weaker, which I think I should practice more, then I can go back to that recording.
All right, no problem. So you want the slides of the stations?
Yes, please.
Yeah, no worries. Yeah, that's fine.
All the information that a role player should have, we have that information in the recordings anyway. So it's just, a quick recall question that I can assess myself, which needs more revision.
There shouldn't be a problem. I will try, but Sadia, I'm pretty busy at the moment, obviously, because the one-to-one sessions going on as well. So the easy way to do for yourself, I know you're busy. I will try. I will ask my admin just to send the slides. That shouldn't be a problem. But in case if I couldn't respond, the best way will be when you're listening those, just take the screenshot of your session, okay, and put into your folder.
Okay.
That could be a way as well, but I will ask him to send the. There shouldn't be a problem. Yeah.
Thank you very much. Thanks. Bye.
All right then. Bye now.